behind. We also, and I know Representative Ballard will be here this afternoon. She had some shit to do this morning. So I want to welcome everyone. It's been pretty exciting to see this committee get started and listen to the work of some of our subcommittees. So what I'm going to do is I'll go ahead and start out with David Fye, our fiscal analyst with legislative research, to provide some follow-up information from our previous meeting. Welcome, Dave.
Thank you, Madam Chair. I'm Dave Fye with the Kansas Legislative Research Department, and you should have a packet of material in front of you for the meeting today. There should be 8 different documents. The second document in your packet should be on a golden sheet of paper. It is a memorandum that's been prepared by our office concerning some follow-up information from the last meeting. And the information that was asked there, it was on this memo, was in response to some of the questions from committee members. And so I just want to walk through a few of these items today. At the previous meeting that was on August 27th and 28th, members asked questions concerning a request for more information on elementary and middle school work related to behavioral health. We were in contact with representatives from the Kansas Department of Health and Environment, and they provided information below concerning some of the sexual violence prevention and education program, the Committee for Children's Second Step Social and Emotional Learning, and then also some information specifically about elementary schools. Another member asked a question concerning additional information on potential hospital beds in Kansas. And Wes Cole, the chairperson for the Governor's Behavioral Health Services Planning Council, noted that some of that information can be found in the Rural and Frontier Subcommittee reports. We provide a link to that information. There was also a request for some information on training and funding for the Kansas Department for Aging and Disability Services, or KDAD's Adverse Child Experiences Program. And that can be found on the back page of that document concerning the ACEs program and training. That's through the Kansas Prevention Collaborative. We have some information about the federal funding and also a link for more information on that program. There was also some questions about what the Department of Agriculture is doing concerning mental health support for agricultural workers. So we provide some information there concerning some information on the website called kansasagstress.org. There's also some information that the agency provided concerning work at the national level by the American Farm Bureau and National Farmers Union, cooperating with Michigan State University on some information and some techniques that they are looking at. They're also speaking about a crisis line that they have prepared employees for concerning some of the swine producers. And then there was some information about disaster relief funding, specifically the Federal Emergency Management Administration's Immediate Service Program within the Crisis Counseling Assistance and Training Program. So we have been in conversation with the agencies. We wanted to get this information back to the committee. And if you have any additional questions, we'd be happy to continue those conversations or find any additional information for you.
All right, any questions? All right, thank you, Dave, I appreciate it. And I should have recognized that we do have over Zoom, we have Senator Pat Petty, Senator Mary Jo Taylor, Representative Elizabeth Bishop, and Representative. Okay, next thing that we've got on our agenda today is an update from our working groups and our roundtable discussion on modernization. And it looks like I'm going to really butcher the name here, Dave. Can you help me out? Ina?
Yep, you did.
All right,
that's correct.
Welcome.
Thank you. Good morning, committee and working group members. My name's Hina Shah, and I'm a senior analyst at the Kansas Health Institute. I'm sorry I couldn't join you for your August meetings, but during that time, you guys carved out the scope for each of the working groups. And since then, each of the 3 working groups has met twice. In their first meeting, the groups discussed barriers and challenges. And in their second meeting, each of the working groups reviewed recommendations for their first assigned topic area. So just to refresh everyone's memory, that was workforce for finance and sustainability. It's prevention and education for the policy and treatment working group. And it's data systems for the system capacity and the transformation group. So these 3 groups are going through reviewing recommendations to set some legislative priorities, essentially thinking through a plan of action. This morning, I would also like members of the special committee and the working groups to collectively think about your vision of a modernized behavioral health system, and specifically really focus on your vision for workforce, prevention and education, and data systems. Now, the reason for this goes back to this old proverb my professor shared. A vision without a plan is just a dream. A plan without a vision is just drudgery. But a vision with a plan can change the world. And here we are, committee. Let's keep this in mind, and let's collectively envision what a modernized behavioral health system will look like in 10 years. What reform will be needed to bring it to fruition, and let's set some goals. What will the future of the behavioral system, healthcare system look like for Kansas? Remember, no vision is too small, no vision is too big, and no vision is crazy for consideration. That's why we've all convened to think through these things. So while you chew on this, I'm going to turn it over to Carly Houchin. She is going to provide an update of the process that the working groups are using to review the recommendations. And the way we're going to work through this part of the agenda is each working group will provide their update. After the update, of course, a brief Q&A if anyone has questions. And then for the remaining time, we'll do a little bit of visioning and really think through what a modernized healthcare system, behavioral health system would look like. So I'll turn it over to you, Carly.
Thanks, Hina. Carly Houchin. I am a senior analyst at the Kansas Health Institute, and I have been facilitating the meetings of the 3 working groups. As I think Hina said, those groups have taken on issues related to finance and sustainability, policy and treatment, and system capacity and transformation. So those are the titles of our 3 working groups. As she said, we're going to hear updates from those working group members in just a moment, but want to provide a little bit more information on the process of what that collaboration has looked like so far. I'll keep this pretty brief, as I know a handful of members of the special committees have participated in some of those calls as well. So first, the crosswalk of existing recommendations that was put together by KLRD and was presented to this group at the end of August has provided a lot of guidance to all 3 working groups. In that document, specific topics and the corresponding existing recommendations were assigned and sorted to each group to try to prevent duplication of effort there. So sorting the work that way. So in the first meeting of each of these working groups, the groups reviewed that crosswalk and basically asked the question, what's missing? So as a reminder, this crosswalk had recommendations that had been developed by 5 previous groups. Those groups were the Child Welfare System Task Force, the Governor's Behavioral Health Services Planning Council, the Governor's 2018 Substance Use Disorder Task Force, the Mental Health Task Force, and the Crossover Youth Working Group. So in that first meeting, the content experts in the working groups looked at the recommendations that had been developed by these previous groups and brainstormed barriers that none of the existing recommendations addressed. So barriers that would be important to resolve in order to have a modernized behavioral health system. Working group members will include in their update a list of those barriers in just a little bit. But kind of process-wise, what we're doing with those barriers is sorting those by topic, and the working groups will address them whenever they kind of take up that topic. So it'll be part of that larger conversation around workforce or data system or whatever the topic for a meeting might be. Additionally, in our first meeting, the groups identified those who had additional or supplemental expertise to the content experts that are kind of regularly participating in the working groups. And again, we kind of sorted those supplemental experts by topic so that they could be invited to the meetings where the group was going to do work related to that topic. So as Hina said, each working group has met twice so far. In their second meetings, the groups focused on a specific topic. So the 3 topics that have been addressed so far, or kind of have been at least gotten the conversation started, was related to workforce, prevention and education, and then data systems. So each of the subsequent meetings of the group will focus on one of the topics assigned to the group. And again, so those supplemental experts can be looped into that conversation, invited to those discussions as well. So at their second meetings, the group accomplished several things. They removed some of the existing recommendations that were no longer relevant or that the group deemed, not critical to modernizing the behavioral health system in our state. They revised recommendations as needed, and then scored recommendations using a rubric that has been provided with meeting materials for today for your reference. So for those who received a copy of the materials via email, that rubric was the one titled like document 03 KHI recommendation rubric. And for those in the room, I believe it's printed in orange. And again, just providing that for your reference. This rubric was developed from feedback received from the special committee after discussion on the August 28th meeting. And the rubric prompts the working group members to assign each recommendation a score for both ease of implementation, a score from 1 to 10 there, as well as a potential for high impact, again, a score from 1 to 10. So recommendations that score highly would then be the things that would be kind of first pass for highest priority. So the working groups are asked to base those scores on considerations such as cost, whether that be cost savings or the extent to which cost might be a barrier to implementing that recommendation. The extent to which sustainability is built into the recommendation, how the recommendation considers equity, the scale of impact, as well as the impact of the recommendations on some listed special committees, on some listed special populations. Additionally, the rubric prompts a key question that I think will also guide some of our discussion here this morning, which is, how does this recommendation contribute to a modernized behavioral health system? So trying to hold fast to that idea of if our end goal here is modernized, so what should recommendations look like to get us there? I would say a request from the working groups for the special committee will be to have some further discussion around this idea of a vision for what our modernized behavioral health system is. And as Hina described, she'll lead the group through discussion to get to some, to help us to articulate that vision over the course of the meeting. But with that, that's really all I wanted to provide in regard to process. I'm happy to take any questions if there are any. If not, I think we could get started with working group updates.
Committee, are there any questions on Zoom or in the room? Seeing that, it looks like you've given us a great explanation as always, so we appreciate it.
Great. Well, our first working group then will hear from the Finance and Sustainability Group. So I'll hand it over to Will Warnes.
Thanks, Carly. The Finance and the Special Committee on Mental Health Modernization, Finance and Sustainability Working Group met initially on Tuesday, September 16th. In that meeting, Carly did an excellent job of laying out for us what the structure of the discussion was going to be like, the rubric that was going to be used, and re-referenced us on some of the expectations of the working group and some of our goals. We talked about some of the general barriers to mental health modernization. I won't go through all of those because a lot of those were discussed in the last meeting of the special committee, but 3 that were discussed a little bit more in depth that had to do with workforce was the critical shortages developing and continuing to worsen in the lack of psychiatrists and prescribers in the state of Kansas, the rural and frontier disparities in the lack of mental health providers, the issue of low pay and difficulty retaining trained staff in the state of Kansas, and then some concerns about a possible barrier was whether there was a need to examine the diversity of the mental health workforce in Kansas. While there's other things discussed in that meeting, when it comes to our point today, when it deals with workforce, I will probably skip forward to our second meeting where we really dived into some of the recommendations from the task forces that had to do with this topic. So the work group met again on October 1st. And in that work group meeting, the first thing we discussed is the recommendations, looking through the recommendations as laid out by the various task forces that are presented at the special committee. And the first thing that was decided is perhaps the child welfare system task force tier 3 recommendation for that DCFS should employ highly skilled and experienced front-end child welfare staff. We decided to remove that recommendation, not because it was not important, but because we felt like it would be discussed in other recommendations that had to do with the mental health workforce in Kansas. We scored the following recommendations. First, the Child Welfare System Task Force Tier 1 recommendation that Kansas should plan for long-term investment in the mental health system workforce by increasing funding for promotion, training, recruiting, retention, and support to effectively attract and retain high-quality staff. We discussed a difficulty in recruiting, which I think is a national phenomenon, but also definitely felt severely here in Kansas. We rated the ease of implementation of this recommendation as a 1 and potential for high impact as a 9. We then discussed the Governor's Behavioral Health Services Planning Council Subcommittee recommendation that the number of clinical supervision hours for addiction counselors be reduced from 4,000 to 3,000. There was some discussion about what legislative actions and or regulatory changes it would take to affect this change. And there was talk that the work group would need to hear more details about this process from the BSRB to help better advise them. We rated the ease of implementation of this recommendation as an 8 and the potential for high impact as an 8. Lastly, we reviewed the Mental Health Task Force recommendation 5.3 about state loan repayment to require a report on increasing the number of psychiatrists and psychiatric nurses in the state of Kansas. We agreed that this would contribute to modernization. The work group did have a conversation about the desire for a report from KDHE on existing state loan repayment programs and the effects and success that it has had in Kansas or lack thereof. We also talked about looking at adding a psychiatric nursing program, working with higher education institutions in the state of Kansas. We talked about the barrier of the high cost of these professions. We did not score this recommendation, but it is going to be scored in a Qualtrics survey to be sent out by KHI, I believe. We then talked about combining the following recommendations into one, that is the recommendation from the Governor's Behavioral Health Services Planning Council Subcommittee to support initiatives that provide tuition reimbursement for addiction counselors equal to that provided to other behavioral health professionals, as well as the Governor's Behavioral Health Services Planning Council Subcommittee recommendation to provide adequate workforce compensation and reimbursement rates for time spent planning and implementing family engagement practices. And then the Governor's Substance Use Disorders Task Force TR19 Workforce Development recommendation to implement workforce development programs to increase capacity of addiction professions. The recommendations that were discussed by the work group was to establish tuition reimbursement, and there was some discussion about emphasizing frontier and rural areas. There was discussion about the pros and cons of different structures, statewide versus frontier focused versus frontier and rural focused. There was discussion about the inclusion of master's level candidates and addiction counselors with the attempt for some parity between what was going to be offered to other professions and these professions. There was discussion about or an emphasis placed on the need to include minimum time working in the designated area. And again, there was talk specifically about the frontier area. There was talk about looking into a pilot program for areas that are especially hard to serve. There was talk about further education for the work group and what is currently being done in Kansas to promote and expand behavioral health professions working within the state of Kansas. And then there was interesting discussion about how telehealth would be factored in to any plan that was designed. What would the work group, what would the special committee, what would the state feel like if a provider was not living in the designated area, such as the provider lived in Kansas, but not in the frontier area, but was designated for the frontier area and serving that area via telehealth. And what if the provider was not living within the state of Kansas and serving somewhere within the state of Kansas? What would our thoughts be on that? There wasn't any conclusions from that discussion, but there was a lot of interest in that discussion, and the discussion will be continued when we talk specifically about telehealth in a future work group meeting. There were a couple new recommendations based on the identified barriers, one of which is what I mentioned before, an investigation into the workforce diversity. I think the work group felt that first and foremost, they wanted to conduct a study or recommend to conduct a study to assess the gaps and barriers related to particular attributes of a provider, whether that be race, ethnicity, gender, or those with limited English proficiency, and whether those are underrepresented in the mental health workforce in Kansas. There was also discussion about the importance to consider opportunities to promote behavioral health widely amongst children 12 to 18 years of age, as it was cited that is an age in which many children are starting to make their initial decisions about the profession they would like to pursue. There was also a new recommendation based on the identified barrier of difficulty recruiting, and there was a lot of discussion about pay disparities amongst mental health professionals in Kansas versus neighboring states. Most prominent of this is the fact that at least two of the four of our neighboring states have been participating in the CCBHC program, which leads to significantly higher reimbursement for services provided, and therefore higher salaries are being offered in our neighboring states, and our mental health system is seeing an outflow of professionals to those neighboring states as they cannot compete with the same salaries. There was some talk also about the importance of considering other models for reimbursement, such as monthly per member per month. Let's see, we'll discuss it. And oh yes, and no conclusions were drawn from that, but it was determined that we will discuss this further in the next meeting on funding and accessibility. So there's some follow-up items that the work group is working on. We're completing a Qualtrics survey on the recommendations that we have not scored yet. And those survey results will be reviewed in the upcoming meeting. And that the work group is wanting to invite someone from the BSRB to provide feedback related to the Governor's Behavioral Health Services Planning Council Subcommittee recommendation on decreasing the number of clinical supervision hours. And the work group plans to meet again on October 14th and then again on October 28th to continue its work. And that's all I have.
Thank you, Dr. Warrens. Chair, are there any questions?
Any questions, Representative Barnberger?
Thank you, Madam Chair. I was writing things down and didn't get it written down exactly. You mentioned that one of the recommendations was to reduce the number of hours from 4,000 to 3,000. What hours were those for?
Clinical supervision for addiction counselors.
Okay, and then this might be a question for staff. I remember 2 years ago, we had a bill in House Health to reduce hours. I think it was for social work. I don't know if you guys can remember. I remember we had Max, and I don't remember Max's last name, that came and spoke to all of us about it.
You have something on that, Dave, and you can do it right there from where you're at.
Wasn't it for nurse practitioners?
I think that you're right.
Okay, I wasn't quite sure. I just remember we reduced the hours, but I didn't remember what it was.
Well, the BSRB has been really good about sitting down with us and working through some of our issues and concerns, as well as their board. I think, we may be to a point where we're kind of pushing them to the max, but it doesn't mean it isn't the right thing to do.
Okay, I wasn't sure if we had some overlap there or if it just.
No, each one is a different.
Okay.
They qualify differently. Senator Alley.
Madam Chair, one of the things which we discussed in our working group meeting was measurement for success. And as I look on the document which we have here, we've had 5 previous studies in the last 3 years. What were the measurements of success in each one of these studies? And what was the outcome of that? And then I think we need to have some measurement of success for this new recommendation that we're putting out.
Who wants to answer that?
This is Hina Shah from KHI. So I think the next steps, once the recommendations are thought through, we will think about outcome measures. But having kind of a plan of action and also thinking through addressing some of the barriers and then compounding that with the visioning that we'll do will really help us set up some good outcome measures to think through progress.
Yeah, thank you. This is Larry Alley again. Do we have outcomes from the 17, 18, 19 studies that we did? Do we have those outcomes?
From like the task force work, am I understanding your question, sir?
Looking for, and Senator, you can correct me if I'm wrong, but you're looking for how do we measure, is there any measurements of success in any of those task force reports provided to this committee?
Right. Well, it looks like to me that we've done these studies every year, but we're not getting a update of are we making progress in these studies? And just having studies doesn't solve the problem.
So
I was not at the oh, I apologize.
Probably part of it is what have we implemented in those studies, and then how are we measuring those successes, and then how will we measure successes of anything else that we put into place going forward? Go ahead.
Agreed, Chair. And I wasn't at the August meeting, so I'll defer. I think I see Carrie online to her, but I believe the agency's provided updates on what has been implemented so far.
I was just going to actually say that, Hina, so you already you said what I was going to say. This is Carrie Bruffett, the Kansas Health Institute. I think as discussed at the last meeting, the previous reports, many of the task force and working group reports you've received we're focused on making recommendations for implementation. So the outcomes measures of those reports, more or less, are have those things been implemented or not. And that's what you did here, an update from the agencies in the last meeting. But what we heard from the committee last time, and that Hina referenced will be part of the work of the working groups, based on feedback from some of the visioning discussion today, will be not just the outcome of did you do it, but what would we expect to see as a outcome in the system if we implement this this recommendation correctly or fully or partially. So that's part of the idea for the visioning discussion as well later. We'll be able to help say, how do we tie to modernization the outcome of individual recommendations? So I think I can speak for I am not a member of any of the working groups, but listen to the discussion that is top of mind or front of mind for the working group members as they're thinking about, okay, how do we make sure when we turn this into a recommendation, what will the measure of success be in 2 years or 5 years or 10 years? And a vision will help them establish that.
Well, and going along with that, Carrie, I think, one of the things that we lack in a lot of our social programs, and I'm not going to speak for the chair of social services budget, who happens to be on this committee here, and he may have some input to provide as well, is that we don't do well in measuring any outcomes of the programs that we put into place. And it's one of the reasons that we've been able to show such a great success and show exactly what's occurring in the mental health K-12 pilot program, because we do measure that on the individual. So I think, it was made pretty clear in our first meeting that no matter what we do in any of these committees, there has to be some form of tracking, showing the successes, so that if a program needs to be tweaked, we can catch that early on and not later after it's become a bigger problem. Everyone understands that, I believe. Is that correct? You're smiling at me, Carrie. Are you shaking your head? Yes. Okay.
I'm muted, but I think that's correct. And that again is part of the idea for the discussion this morning, to get some more thinking about not just individual recommendations, what's a successful outcome for that individual recommendation, but how do you vision what a modernized mental health system looks like, or behavioral health system looks like around each of these recommendations. And that will really help the working groups form up some really meaningful measures for the specific recommendations as well.
Did that help, Senator Allen? Eileen has a comment.
Thank you, Madam Chair. Representative Arnberger is really correct, or mostly correct. Last year, House Bill 2603 would have reduced the hours from 4,000 to 3,000 clinical supervised hours for professional counselors, and then also reduce from 150 to 100 hours of face-to-face clinical supervision, and would have been defined by the board of rules and regulations. And it was not voted, it didn't receive a hearing, it was not voted on, but it would also have included less than 50 hours of individual supervision.
Thank you, Eileen.
Madam Chair, I have a question.
Yes. Who am I talking? Who do we have here?
Representative Ballard.
Oh, Representative Ballard, you're on Zoom. Okay.
Oh, yeah. I will join you this afternoon, but I'm on Zoom now. Dr. Warren did a fabulous job, and I just want to make another comment about those hours. We had a discussion about that, but before we could do it, we would like to look to see what would happen if we reduce those hours. I mean, what's left out, or what training wouldn't be covered. But the idea was that for some, it would help them financially. For others, especially in the area where you're dire to have more counselors at that point. But the suggestion was made for those reasons. But we also, I just want to just make sure we know, we would look to those people who are actually giving those degrees and wanting those hours, to find out what would happen if we reduced it. Does it minimize the training in those areas? So that's the only thing I would just add to that.
Thank you, Representative. Other comments? Senator Taylor has a question, I believe.
Yes, thank you, Madam Chair. I just wanted to say that being a member of a rural and frontier area, a lot of the things that Dr. Lawrence had to say were resounded very fully. I represent Larned State Hospital. They have a tremendous difficulty recruiting, and especially recruiting the psychiatrist and the nurse psychs. And in fact, the person who is the psychiatrist at Larned right now is not from Larned. He comes from Kansas City periodically. So definitely a big need for those professional people that work in those professional areas. You might think, well, maybe we should move the facility from Larned to someplace else that has more people, more amenities. But it does, regionally, it employs over 3,000 people, 21 counties in this part of the state. So it is important to try to keep that as a viable option as long as we possibly can. The other thing I was going to say or comment about is telehealth. I used to be a superintendent, and for over 20 years, before we had laptop computers, we had these great big, I don't know if you guys have ever seen them or not, these great big encryption units, and we got a grant to buy one, and our students who are high free and reduced lunch students took advantage of this, and they had an outstanding psychiatrist out of KU Med who did it. He retired, unfortunately, but this is an anecdote just to let you know that it worked really well in concert with the doctor, as well as then the local counselor who could follow up on these behaviors. And again, that's just an anecdotal thing that's really helped us in a rural and frontier area with our children. I'd say grades 2 to 12 has been really good. The other one more comment I'm just going to make, as far as measurability is concerned, we have to have legislation before we can measure it. It seems to me. So that's maybe part of our holdup. And with that, I'll just stop. Thank you.
Well, I think where we're at, Senator, is that along with the legislation, I don't believe that we want to see anything come forward to the legislature to be presented without some kind of a measurement scale in there.
Of course.
It's one of the issues that we've had for many years. It's not a new issue. I also believe that going through this pandemic, telehealth has played a very important role. It has expedited the use of telehealth faster than I think it ever would have. Mm-hmm. And so one of the things as we go through this process is trying to figure out, okay, what do we need to do, if anything, on a legislative perspective to actually provide some guidance on the telehealth. I know that there's some experts out there that have expressed concern that providing mental health services for kids of certain ages is probably not the most conducive or best for them. So those are kind of some of the things that we're looking for. How will it actually work, et cetera. So it's been a good pilot for us on a crash course. Further comments or questions?
Yes, Madam Chair, I have a question, or I have a comment.
Okay.
I wanted to interject previously when we were discussing the reduction in the required hours for certification. And I recalled that we did that a while back for social workers, and was pretty sure, I know it passed the Health Committee. I'm pretty sure it also passed the legislature, and I think that's been reported on. And I have to confess that my internet went down briefly when that was the actual bill was discussed. So I'm not exactly sure what was said there. What I recall from the conversation in the Health Committee is that it is especially a issue where the surrounding states around Kansas do not require the the same level of supervised hours and so forth that we do here in Kansas. And especially in the Kansas City area, there were social workers living in Kansas who were driving into Missouri for their jobs because it was easier to qualify than it was in the state of Kansas. And there was general consensus that that higher level was no longer absolutely necessary. In addition, during the last session before the pandemic kind of took over, I was in discussion with the staff at KDH&E who are responsible for the programs dealing with underserved areas. And we were looking at the federal programs, both scholarship, loan reimbursement, and so forth. And one of the things that I learned is that the city of Wichita and area tends to not qualify for those programs because of the federal scoring. And I think our score is about a 17 or something like that, which puts us out of the running. And in part, it's because the formula appears to include things like the psychiatric social workers and psychiatrists that are associated with the VA, who basically only serve VA patients, which is a good resource for the community, but it's not a general resource. And just some other issues like that, perhaps retired psychiatrists who are keeping their license current just in case they want to complete some of their ongoing patients before they retired, but they're not really serving as the kind of resource that we need in Wichita. I think that that's an issue. I was looking at a program in Texas that provides state support loan forgiveness over a 5-year period for social workers that will serve in underserved areas. And that looked to me from examining the program, and it's been a few months now since I've looked at it, it includes some areas that we would truly regard as urban. And I think we need to look at both. I know that there are rural and frontier underserved areas, but there are stresses in the urban areas as well. Thank you.
Thank you, Representative. Anyone else, comment, questions? Way by Lean's got an update to provide us on legislation that we have out there.
Madam Chairman, I might mention that the staff person that I have on file in my contact list for KDH&E is Kendra Baldridge. I believe there's a staff of 4 or about 4 persons who are devoted to looking at how to serve underserved areas, and that should, at least to some extent, include urban areas.
All right, Eileen.
Thank you, Madam Chair. With thanks to my 2 revisor peers that are out in Easterland, in 2019, Senate Bill 15 passed, and it reduced the number of supervised hours of social workers from 4,000 to 3,000. And then to answer some of the reciprocity questions, the bill also allowed the board to issue a license to either professional counselors or social workers who had certification or licensure to practice professional counseling. It's a current provision that dropped the number of months immediately preceding the application from 60 months to 48 months of the last from 66 to 54 months of that were immediately preceding the application. And the applicant had to have at least the minimum of professional experience established by rules and regulations of the board.
Does that help? All right, thank you very much, Eileen. I appreciate it. Now we're back with KHI, I believe.
Yes, so let's take the next kind of 5 to 6 minutes before our working group to update. And I'm going to pose the question, what will the workforce look like in a modernized behavioral health system? I completely understand that measures of success are important, and the working group is also going through recommendations, and we'll definitely flesh out more measures during the October 30th meeting. But right now, I really want the committee and the working group members that are in attendance right now to think through what is the vision, because this will help inform everything. So what will the workforce look like in a modernized behavioral health system in Kansas? And what are some high-level goals and their desired outcomes for success? So would someone like to volunteer to kick off this discussion?
Did you have someone on one of the working groups to do that?
This is Senator Petty, and I'll just start with, I think that we are learning quickly. Oh, Madam Chair, if you were, sorry.
Oh, you're fine, Senator, go ahead.
I think it sounds like we're learning quickly in this last 8 months how important telemedicine is going to be. And it's just going to be because throughout the state, our constituents and our providers are becoming experts at using telemedicine, and our constituents are becoming more comfortable with it and finding that it avails them of the opportunity to get services that they might not been able to have because of distances. If we talk about the frontier, I think Senator Taylor spoke to that with what her experience as a superintendent. So if we can say one positive about what the last 8 months have done to help us as legislators, I believe, and our constituents, is that this definitely telemedicine and the availability of it and how we can, as a legislature, if necessary, help to make it more accessible and available is critical.
I guess one of the things I would ask after on the working groups is, has there been any discussion along with because I agree with the telemedicine, the telehealth, is the discussion of making sure we have in place more often than not electronic medical records? I guess there was no discussion on that.
Yeah, this is Will Warren. Sorry about that. There was no discussion about that, but that is something I could take back to the working group, and we specifically could discuss, because that's a very important issue.
Well, I think we've had that in place for a lot of years in Kansas. So it's like, okay, how do we expand that and make it go hand in hand with the work that we're doing on the telehealth and telemedicine? So I appreciate that. Other questions?
Madam Chairwoman?
Yes.
There was also, this is Rachel Marsh with the Children's Alliance. There was also discussion on the prevention and treatment group about the need for information sharing and data exchange, especially related to prevention. So I wouldn't say we called it electronic medical records, but we probably will be circling back to that as an issue.
Okay, that's a good point. Thank you, Rachel.
Madam Chair?
Yes.
This is Kyle Kessler, and not to leapfrog anybody, but that was also a point of conversation in the System Capacity and Transformation working group. It certainly seemed to intersect pretty well from health information exchange to electronic medical records and some with the telehealth. So I'll talk a little bit more about that in our report, but there were certainly some conversations about EMR specific issues during our last meeting.
All right, thank you. Anyone else? Comments? All right, back to KHI.
So I'd like to stay away from the details of this, and definitely EHRs are very important and successful outcomes are very important. But I'd like to go back to really thinking through, what do you want the workforce to look like? I'm hearing telemedicine. So do you want, I think Dr. Warren had brought it up earlier, do you want the workforce to just be highly mobile? They can live anywhere and be mostly interacting online, or do you want the workforce to live where the people they are serving. That was another important criteria with community health. Or do you want the workforce to be, brought in? Is it recruiting that you want to think about, bringing in others with pay and, loan repayments? Or do you want to think about growing your own, and really drilling down and getting that age 12 to 18 group and start to build in programs in high school so that, you have a sustainable workforce that way. I really want to bring us back to what do you want this workforce to look like in 10 years so that we can think through steps to make that come to fruition.
Madam Chair.
My comments on this would be that, my vision of the workforce is anytime that we can make it local in the community, I think should be our #1 priority. But we also know because of the makeup of our state, that's not always feasible. So that's where I think the telehealth and the telemedicine comes in place, so that whether it's someone in another area of the state or even someone that's from out of the state, and how would we address that? I think I can envision that part as well. I think it's also important for us to have the ability that no matter where in the state of Kansas, should a crisis arise, that we're able to send out a team if we have to a specific area to help them, address, devastations and different things that might come up in their lives. So I think it's a combination, but I think the focus should always be #1 priority, being trying to have it in the community. I do like the ideas of how can we take and grow this in our schools with our young individuals, having those conversations with them. And, perhaps there's some of our colleges that do currently work with credit hours within our high schoolers, that we can, look into that and see if there's any of that currently going on in this particular profession. And if not, how we can make that happen. That's my, anyone else?
Madam Chair.
Elizabeth Bishop.
Representative Bishop.
Thank you. I want to mention once again some of the needs that exist in urban areas. Robin Chadwick, who is the head of psychiatric services for Ascension Via Christi here in Wichita, has talked about, sorry. That will stop in a second. Has talked about the fact that it's impossible to expand in patient services, especially those that go overnight, unless we, thank you. Sorry about that. I had it turned off, but unfortunately it was close enough to my MacBook that it set it off anyway. That it is impossible to expand in hospital psychiatric emergency services any further, and although there is a need, because of the inability to acquire enough staff to truly do it. And I have heard her give extremely cogent presentations on that fact. And that in hospital, even if it's temporary, even if it's for a while, is very much needed, because otherwise they are actually boarding them and not able to move them on within the system to receive the level of care that they really need. Thank you, Madam Chair.
Madam Chair.
Representative Smith.
Thank you, Madam Chair. I just wanted to agree 100% with your comments from earlier. As a legislator that lives in a frontier county, extreme western Kansas, where a majority of the counties out there are frontier, very low population. I agree. It's nice to have some very highly skilled resources within your community, but we always understand that it's not feasible. So in our communities, a lot of times that does have to do with the mental health services. And having someone available via telehealth is better than nothing at all. And I just, every word you said was spot on, and I wanted to commend you for that. That's exactly what I see from the frontier counties.
I appreciate that. I do have a lot of family out in western Kansas, so I do think about those folks. And I appreciate your comments. Senator Allen.
Thank you, Madam Chair. We heard during our working group meeting that a lot of the staff, they would train them and then boom, they're going to Oklahoma, they're going to Missouri. So the question, I think, for our staff here, perhaps they could give us what's the requirements, like 3,000 hours or whatever the hours are for surrounding areas, and are we reciprocal with them? For instance, Oklahoma, are they at 3,000 hours today? And we'd be losing staff moving to Oklahoma, we're losing staff going somewhere else.
And someone can correct me that knows this probably better than I do, but I think when we passed that legislation for reciprocity, that we addressed a lot of that. The biggest issue that we're facing is that, and I think Kyle Kessler is real familiar with this, is when the federal government allowed an option for us to, and I don't remember the name of the program. Can you tell me, Kyle, where the reimbursement rate would have been higher on the mental health?
It's the CCBHC program. So it was the Excellence in Mental Health Act, but it was this Certified Community Behavioral Health Center. So that's what both I think you and Senator Alley are referring to, I believe.
So the state of Kansas didn't opt into that. And when they didn't, that put us in direct competition then with our surrounding states that did do that. So if you're sitting close to a border, where are you going to go to work at? The place that pays you a bigger paycheck. So I think as far as reciprocity, I think we're pretty good shape on that. But again, I have to just say is that the BSRB has been very good about understanding these concerns and working with us. And I know we're pushing them, I think, a little bit far, but I think we've got to do what we have to do to get what we need out there. So.
Madam Chair?
Yes?
Deb Stidham, Kansas Association of Addiction Professionals. I'd like to talk just a little bit further about the reciprocity issues with surrounding states.
Yes.
So I also serve as the chair of the Behavioral Sciences Regulatory Board. So I just want to say that the BSRB has discussed, at length what we should do about the fact that the social workers' hours have been reduced and the impact that that has on folks, deciding to go into social work now as opposed to professional counseling because the hours are reduced. And so we've decided to go ahead and do that uniformly across all of the disciplines. So I think you can look forward to that legislation next year, and I think that will move that along. So to speak to a little bit to the concern about the reduction of hours, that kind of homework, if you will, from social workers when that bill was passed has already been done to show how out of whack really Kansas was compared to other states. Really, it just became difficult, at least from my position, to justify the amount of hours that Kansas was requiring. So I think part of that is just we operated in silos. When you pass bills and God only knows how long ago that was done, you don't know what the other states are doing or you don't know the impact of that. So I think the other piece that I would just like to share from the BSRB's perspective and my role as chair is that I think it's vitally important that the board consider reducing barriers that exist in treating folks, and that including, how onerous are we making it to become a licensee? Now, we don't want to do that at any cost, but I think we are in the position of creating in our zest for competency, however you define that, we're actually keeping people from serving Kansans who need those services, which to me is not protecting the public either. So again, no easy answers. It's a balancing act, but I am confident that the board will continue to weigh out those kinds of options and introduce legislation next year and beyond that is going to continue to move that needle. If I could just take another couple minutes and beg your indulgence just to talk a little bit about a committee that I chaired also. It was a workforce development committee. SAMHSA convened this back in 2015, 2016. I worked with the then state leadership and convene we had all kinds of folks coming to the table, and the whole entire purpose of that was to look at how can we improve the access, retention, and competency of the behavioral health workforce. And so I guess I'm struck with just a couple of takeaways, kind of going back to vision. So first off, and this is a little bit of a deviation, just to talk about the fact that we don't have great data about what we need. So I know on the substance use disorder side, there hasn't been a needs assessment done of that particular population of who needs our services since 2005. So that obviously that needs to be updated. We need to understand, at least in that population, what's out there. Who are they? What's their age groups? Where do they live? What are their needs? And I think you take that data and then you convene a comprehensive workforce study and you say, what do we have? And what's the gaps? And to me, it's an overlay of what the need is versus what we have available. And then we resource it. And there's a lot of strategies being proposed. And I think that's exactly what we've done in the last 10 years or more, is just do these kind of, well, here's what we need here, or here's what we need over there. And there's somebody interested in putting that forward. So Nebraska's already done this. They did this, gosh, I don't know, 10 years ago. The legislature convened they put money into a center that does nothing but work on workforce development for behavioral health for the state of Nebraska. They produce reports. Those are available on the internet. It's a comprehensive approach. We need everything. We need to recruit high schoolers to be interested in behavioral health. We need to equip the people currently in the system to keep pace with current trends. We need to look at the loan repayment programs like you're talking about. We need to target for certain areas to do certain things. This is what a resourced organization will do for a state. There's no state office, KDAS, KDHE, BSRB, nobody's equipped to deal with this today at the level that it is needed. So thank you.
Well, and I appreciate your comments, and I wish I had a list in front of me of who all is out there. But I do have to reiterate that I think the BSRB has been very helpful for us, and they have listened as we've expressed our needs. So we do appreciate that. I think that you bring up a very valid point, and I wish that I'd been the one that had thought of this, but I didn't, you're correct. We don't have just a specific area or one place that we can go to and say, all right, what is the workforce need and what are we doing to get there? Because it's fragmented within the different agencies. Did you have a comment? Then don't look at me that way.
Madam Chair?
Yes.
This is Kathy Bush from the State Board of Education. At the state board level, we have worked with our local universities, and they've done an amazing job because actually, believe it or not, we have a shortage of teachers, and they have gone out into these communities throughout the state and are delivering programs to people. For instance, we start with paraprofessionals who are already working in that community and are getting them the instruction that they need, the curriculum instruction that they need, but then the actual experience, and they are becoming teachers. So we have a pathway directly in those communities from their current job, whether it's paraprofessionals. We actually have a few universities that are doing programs, and they're doing a grow your own teacher program starting in the high school. So I think it's doable for our behavioral health systems. We've started it in education, and the universities have been quite innovative as far as how they're doing that and how they're working with us throughout the state. So some folks can stay in their own community and get the training that they need to be trained and then provide those services in those communities. So it is happening honestly throughout the state.
Appreciate those comments, Kathy. Because that's a good idea. It kind of goes along the ideas, how do we take and centralize this a little bit so that we have one place to go to find out what we're doing, what we're not doing, and how we get there for the community stuff. Other comments?
Madam Chair.
Yes.
Go ahead.
Madam
Chair, I do have one comment here. I think with that workforce, we need a highly trained workforce. I know we get people at the state hospital who come. Go ahead.
All right. Who's commenting right now? I didn't hear a name. Somebody was commenting out there, a gentleman.
Okay, Madam Madam Chair, this is Wes, and I do have a comment.
Okay, there we go. All right.
Okay, and one of my comments is what I think that we need a workforce that's highly trained. I think training is a critical issue. I know at the state hospital, we hire professionals that have their degrees, nursing degrees and things like that, but they don't have a lot of training. We have to really get involved and make sure that we have a highly trained workforce. I think that's going to be a real key.
Thank you, Wes. Senator Taylor?
Thank you, Madam Chair. I just was coming around to the original question of what is the vision for us going forward. And I think everybody has really astute answers to it. But I do want to add that I think that we, while frontier and rural areas will take telemed over anything else, that is the last resort. And as we go along, if we can find a way to encourage professionals, psychiatric nurses, psychiatrists, to be lured to more rural and frontier areas, or even areas adjacent to them, whether it be Hayes, Garden City, that sort of a thing, that it will raise the quality of life in those areas. And that's another, I know it's a sidebar to what we're talking about today, but to have a lot of educated people in a community heightens the whole value of the community in many ways. I just wanted to add that on. Thank you.
Well, I know that becomes difficult. We kind of ran across that a little bit when we started out with the K-12 mental health pilot program. Was the first year, the requirement for a liaison was to master level social worker, and that became really tough. And we got fortunate that we actually had a couple of individuals that chose to move back to Kansas and move back out to rural. And I think, it takes a special person to decide that they're going to live out into the rural areas. We can train a whole lot of people and try to get them out there, but unless they decide that they like that life, it makes it really hard. But it doesn't mean that we don't try to encourage that in a lot of ways with our training. And I think Eileen's got some hours for our surrounding states on the social worker training. Go ahead, Eileen.
Thank you, Madam Chair. I just did a little bit of research online just now. Oklahoma requires 4,000 hours of supervision for their licensed social worker program. Missouri requires 3,000 hours, and Nebraska also requires 3,000 hours.
So the BSRB brought us right in line where we needed to be. Representing Arnberger.
Thank you, Madam Chair. I just have a comment to give to the working group chair, or maybe this is brought up in your discussion or not. But Fort Hays State University expanded their social work program, and so I don't know if that's been discussed. I'm looking on their website right now, and they have different cohorts in Colby, Dodge City, Garden City, and Liberal. And so I don't know. They're very granted, I'm a Fort Hays grad, so I'm kind of biased, but they are always looking at how can we fix the gaps that are in Western Kansas. And so I don't know if that's something too that Dr. Tisa Mason might be in a great resource on. This is a situation that we have going on in Western Kansas. How do we fill these positions, and if they can work with us? But I'm just throwing that out there that I know they really worked hard on their social work program. And I don't know if they might be some resource to this committee on certain positions that need to be filled.
And I actually think that's somewhat been mentioned because they were amongst the first that approached us as we were looking at this here a couple of years ago about, what could they do? And then they did step up to the plate. So that's a very good point. Other questions and comment? What I will ask those of you that are on Zoom, if you'll make sure you let us know who you are. If you haven't just raised your hand so that my staff can identify that you're wanting to speak, I would appreciate it, because unfortunately I don't recognize everyone's voices. So anyone else with questions or comments on where we're at? Or do we go back to KHI at this point?
Madam Chair?
Yes.
Yeah, this is Will Warrens again from the work group. I do think when we talk about vision, and this may be right or this may be wrong, maybe short-sighted, I feel like this subject is a little different than our other two subjects, because I feel like this subject of workforce I do get the impression my back is, well, our backs are against the wall and we're trying to respond to a crisis and a growing crisis. And so my thoughts, because of that, get pretty basic. I wish we could be adding bells and whistles to our workforce, but I'm focused on number of specialist hours per capita per county, whether that is frontier, rural, or urban, to not decrease and start increasing. So I'm just thinking as I'm responding to what is our vision, I feel like my vision for this subject is a little bit more basic than in some of the other subjects, just because of the crisis.
Well, I would have to agree with you that, you know, I think we've been in a crisis for quite a while.
Yes.
I think just a lot of things that have brought it to head. And I think that with my years in the legislature, it has been nice to find out that we finally have people that have given mental health the attention that it deserves. And so that's why we are where we're at today. And I think we've got a lot of good people across this state and involved in this committee to kind of help us get there. So you're right on target with where we need to be. And it's starting out with the basics, and then we figure out how we get to the bells and whistles. But we've been in crisis for quite a while. This isn't a new crisis. Senator Allen.
Thank you, Madam Chair. Along with that comment, do we have that information of how many hours we are doing in each one of these counties? Do we know how much we're spending? Do we know what the need is?
Did anyone answer that? Because I think I know that the answer would be no. But I'm not the expert. Someone out there on Zoom?
Madam Chairman, this is Sandra Berg with United Healthcare.
Yes.
As a managed care organization, we do have geo access that we can see who's available in each county to provide services. The one thing that we don't necessarily collect is what is their availability as far as adding new patients or new clients to their caseload. So that's a challenge that we have within our system, is being able to identify who truly is available to provide those services.
Senator Allen.
Thank you, Madam Chair. That's one part of it. But the other part of that question is, what's the need? I mean, and let's just say in Greeley County, what do we need in Greeley County? What do we need in Cheyenne County? Those are what we need. So then we can start looking at solutions for where we place the people.
Madam Chairperson, this is Hina Shah from KHI.
Okay.
I completely understand. I think one or two of the recommendations were focused on doing a needs assessment and thinking through what the workforce needs are. I think Deb Stidman also talked about how a needs assessment hasn't been done since 2005. So I think this is a recommendation that will be discussed by the working groups and put forth for this group. And just like Dr. Warren said, problem solving and visioning go hand in hand. I mean, they work together. The problem is getting away from something negative. The vision is really trying to push towards something positive. And so thank you for your comments on that. I also wanted to see if the chair of the working group, Greg Hennon, is on now, if he had any comments. Otherwise, in the interest of time, Madam Chair, we may want to move on to work group 2.
Madam Chair, if it's okay that I comment?
Yes.
Yeah, this is Greg with 4 County Mental Health Center. Just a couple of things. First of all, I think you're spot on when you talk about the fact that it's important to have professionals in the community. It's great to have televideo and telehealth types of services. That certainly closes a gap for patients. But having a professional physically present drives the culture of the organization. And when they live in the community, they are involved in Rotary Club or Seroptimist or whatever it may be. And that helps establish collaborative relationships with community partners, whether that's law enforcement or hospitals or whatever it may be. And as we're being driven to do more integrated care and to do good care coordination, Having someone that's available, that lives across the United States and they're just available to see a patient on a screen really doesn't fulfill our entire community-based mission. So I do think we need to have boots on the ground, if you will. And we're an organization that does recruit from the high school. When kids turn 18, they oftentimes come to work for us, particularly after school program or summer program for our children's psychosocial. And they go from being aides to ultimately case managers. And we have an internal scholarship program where we help people get their master's degrees. So despite that recruitment process and their continual progression, last week I lost another therapist into Oklahoma to the CCBHC system. I now have 8 therapist openings. And we're a group that trains our own, and I can't hold on to them. So being fully resourced is critical for us being successful. That's all I've got. Thank you.
Thank you. Back to KHI.
Thank you, Madam Chair, and thank you for everyone's comments. I think this definitely gives us a good vision that we can put forward, and we'll detail those out and report out on October 30th. So now I'd like to invite Rachel Marsh to discuss Working Group 2.
Just before we go on, I think going back to the needs assessment, it does sound like to me that it's something we might be able to expedite a little quicker than we did back in 2005. Because it sounds like, and I want any of the MCOs that are on there to correct me if I'm wrong, but it sounds like the MCOs may have the bulk of that information. Would that be correct?
Yes, Madam Chairman, this is Sanderberg. We do have information on the network and what is available and where our gaps are.
That gives KHI a resource and the working groups to go to. So,
Madam Chairman?
Yes.
This is Representative Elizabeth Bishop, and sorry to just break in, but before we move on, I just wanted to mention that we know that we will be having some sort of a spike in need starting in the middle of the year next year, because that's when the 988 crisis line comes into effect. And I'm expecting that will increase the need for services, at least to some extent. So I think that Deb Stidham is right on the money in terms of us needing to do, and you as well, of us needing to do a needs assessment so that we can get prepared for that.
Madam Chair?
Yes.
Deb Stidham, can I comment?
Yes.
I just want to go back to the needs assessment. So it's kind of 2 parts. What are the needs of our Kansans with substance use disorders? What are their needs for treatment and different types of interventions? And I fully agree that the managed care organizations have a lot of wonderful data. When it comes to a lot of the folks that we treat in the system, though, they are not Medicaid eligible. So that's why it's important to have a different type of study that's going to evaluate the needs of the indigent who have no access to Medicaid or other payer sources for their services.
Yeah, and I didn't mean to imply that it would only be our MCOs. It's just that they've got a valuable resource that we didn't have back in 2005 to bring to the table. And that's why, we have the private insurance providers online as well, and some of our CMHCs out there, and I got QHCs. So back to KHI, and we'll move on to the next working group.
Thank you, Madam Chair, and I'll invite Rachel Marsh to report on Working Group 2.
Good morning. This is Rachel Marsh. I'm one of the co-chairs of the Prevention and Treatment Working Group. I'm going to just highlight some of the conversations, and in the interest of time, it will be very, very high level. If there are subject matter experts on our group that need to clarify something related to the mental health terminology, please definitely feel free to step forward. In our first meeting, we discussed general barriers to prevention and treatment. And you'll not be surprised to hear that the very first one mentioned was the workforce shortage. That was a very common theme. We talked in related issues about timely access to behavioral health care, whether we have adequate provider networks, whether our providers have the education and the training that we need. There were a lot of discussions about children's services and specific niche areas in the child mental health arena, such as PRTF, juvenile justice, crisis services. Our group discussed a lot of suicide prevention, lack of coordination as a barrier to mental health treatment and health. And many of the discussion points that we reviewed related to adequacy of funding, whether people were mentioning how to bill Medicaid in such a way that we're reflecting really what the service is being provided, or specific service codes for substance use disorders, or the need for broader recovery and substance use or other specific behavioral health areas. Funding and barriers to reimbursement was a constant theme throughout the discussion for prevention, education, as well as treatment and recovery. We mentioned earlier that information and data sharing to support the continuity of services and mental health care for individuals and families was a recurring theme as well. Again, reflecting the conversations we've had this morning, access to telemedicine and telehealth. We also talked about, from a prevention perspective, housing and employment supports, the importance of continuity of services and continuity of care, and of course, the ongoing issues related to adult psychiatric hospitalization options. In our first meeting, we identified some supplemental experts that we wanted to include. We identified someone from the IDD community and further experts from substance use disorder treatment field, as well as someone to identify the perspective from colleges and universities. And then in our first meeting, obviously, we went over those other things that I outlined, kind of our group approach and processes and procedures. So then in our second meeting, we focused on the prevention and education aspect of our work group task. We actually reviewed all the recommendations and decided to really focus on ones that had a strong potential for impact, and to not focus on a number of ones that we felt probably were not going to have that high impact from the perspective of the mental health modernization and reform perspective. So we decided to not score the child welfare system task force related to recommendation related to safety net, early childhood, and early intervention as being so broad that we wouldn't know how to score that in a broad way. We also did not score the evidence-based practices work group for behavioral health promotion, as we didn't want to focus on scoring a work group since we are a work group. We talked about not scoring and a couple of other recommendations from the Governor's Behavioral Health Services Planning Council and Substance Use Disorders Task Force that have to do with continuing education and publicizing availability of prevention tools. And we also didn't focus on the recommendation related to K-TRAC's guidelines. So having gotten those out of the way, we did have very robust conversations about a number of topics. And I found interesting as I went through to prepare my notes for this, that two of the three topics we did focus on, and the ones we thought had the most potential for impact, have relate to early childhood services. The first, I'm not sure in chronological order, but the first one on my list is the Governor's Behavioral Health Services Planning Council Subcommittee recommendation related to providing resources to early childhood programs and implementing and sustaining the Kansas Family Engagement and Partnership Standards for Early Childhood. We discussed that this would have a very strong score for ease of implementation as well as for high impact. The next one that we scored was the Mental Health Task Force recommendation related to early intervention. And that has to do with increasing access to early childhood mental health services by including language in the state Medicaid plan to explicitly cover early childhood screening, assessment, and treatment. We thought that that would be less easy to implement, but have a strong potential for high impact. Finally, we discussed another very serious current issue related to suicide. The Governor's Behavioral Services Planning Council Subcommittee recommendation related to suicide that our group reviewed had to do with, is a very broad approach on suicide education and support for treatment services. It includes both writing and disseminating a marketing kind of strategy statewide, as well as increasing provider trainings and mandating those trainings potentially, and working closely with the BSRB. So our group, due to a little bit of the broadness of that category and the different subparts of that category, weren't sure we would be able to implement that very easily, and that we weren't sure it would have the high impact that we would want to have on suicide and the modern mental health system. So we gave that a 5 for potential for high impact. There were 2 recommendations, if I can scroll back up, that we wanted to refer to other working groups. One was the Governor's Behavioral Health Services Planning Council Subcommittee recommendation related to housing, creating a housing specialist certification and ongoing education training. And also the recommendation from the Substance Abuse Disorders Task Force about medication-assisted treatment training. So we through KHI will be referring those to other working groups. So at the end of our conversation about the specific issues related to prevention and education, we went back to kind of the beginning and looked at identified barriers kind of from a broader lens of for prevention and education broadly, and in every instance issues of funding came up again related to statewide implementation of a prevention specialist certification that we thought that we might need to look at that, but that would need to be and we would need an investment in that. We thought we would need to continue to increase funding for suicide prevention, as those services are a barrier, or lack of services, and education is a barrier. And also we need funding to provide better education for parents who don't know where to go when their youth or child is in a mental health crisis. So those are the highest level that I could try to summarize for this group. Much more detail, much more specific technical barriers identified, but those are the themes. Our next group will be focusing on more of the treatment and recovery aspects of our charge, and then we will be focusing on the special populations after that. If there are questions, I'm sure I will need Hina, Carly, or members of our group's help.
Any questions? You must have just floored everybody, Rachel. Do we have someone on Zoom that has a question? No. Oh, Representative Lynn.
Thank you, Madam Chair. I'm just wondering, and I'm trying to scroll through here real quick. I just want to make sure that veterans are included in the special populations that are being looked at.
Thank you for that, Hina. I'm sure you'll take that comment.
So they haven't been, or they will be, or?
I actually don't have the list, but I think we can add it to our list.
Other questions or comments for Rachel or anyone with that group? All right, seeing none, I think you've done a really good job with that. So we're ready to proceed forward.
Thank you, Madam Chair. Hina Shah, KHI again. And again, I'd like to take a few minutes, just 5 minutes, to think through what our vision for a prevention and education system or program looks like in a modernized behavioral health system in Kansas. What's our goal? What are some high-level goals or outcomes for success? What do we want in place over the next 5 to 10 years to prevent suicides in the future, to prevent child abuse, to educate populations to think about special populations? And again, would someone like to kick off the discussion?
Madam Chair?
Who's this?
This is Kyle Kessler.
All right, Kyle.
And just to kind of go back to Representative Lim's question for just a moment, and I think that it segues very well to Hina's question about how to reduce suicides and engagement in the child welfare system. And some of that is identifying at-risk populations. And we know that veterans, in terms of the trauma and isolation that they feel, are one of those. Probably Wes Cole could speak to this much better than I, but I believe that the Governor's Behavioral Health Planning Council has a subcommittee on veterans. So, I mean, there is that constant conversation, and certainly there's a large number of veterans with McConnell Air Force Base and Fort Riley and all of the National Guard and Air National Guard installations we have around our state. So I think that it does start with whether it's veterans as well as farmers and ranchers, youth suicides, looking at those populations and figuring out how to engage them is key.
Madam Chairman, this is Sandra Berg with United.
Yes.
I just want to tag on to what Kyle was saying about the populations, but also looking at their points of entry into the system and where they access the system and how we can help people get to those points of entry a little bit better. We are seeing some folks who have never entered the mental health system going in through the emergency rooms and through hospitals rather than lower levels of care. Which can be pretty traumatizing when someone's in a mental health crisis and they have to go sit in an emergency room. And it just isn't the best point. But I think as part of prevention, we need to see where they are entering the system and how they get their services.
Okay. Other questions or comments?
Chairman Landmer, this is Secretary Howard. I would just say, maybe taking this up a few feet, that I think when we think about prevention, that it's really important that we take a population-based approach, and also that we really think developmentally across the lifespan. I think that's really important. And this piece probably goes without saying. There's obviously been a lot of work on this in recent years, but that our approach should be really trauma informed.
What was that last comment, Secretary?
Just that our approaches be trauma informed. Now we need to take trauma into account. So really trauma informed services as we think about prevention.
Thank you. Other comments or questions? Senator Allen.
Is there a relationship between the mental health and the suicide and employment?
I'm not sure I understand your question.
If one is employed, do they have as much, does that employment group have as much mental health issues as those that are unemployed?
Senator McGinn.
Thank you. I'm not sure if it's in our packet from last time, but if you look at the suicide rates, the 20% of the women that committed suicide, it was job related, that they didn't have jobs and they were taking care of their kids.
Anyone else have a comment?
Madam Chair, this is Kyle.
Kyle.
Yes, and Senator Alley and Senator McGinn are both correct. And I was just feverishly looking around for a study I had on my desk last week that I think I may have even testified about, that either the World Health Organization or the CDC in a recent study cited unemployment as a risk factor for suicide.
Senator Allen.
So my follow-up question would be, would one of the preventions be more employment?
You want to respond to that, Kyle, or someone else?
I'm sorry, I didn't hear the question.
Would part of the prevention solution be more employment?
Yeah, I think so. And there are, and Secretary Howard has a better beat on that with both DCF and KDADS. I think the employment related programs that they're pursuing are significant. Housing also being one of those. But certainly the stimulus packages related to the pandemic were intended to try and create or sustain jobs. So probably Secretary Howard could speak to that better than I.
Secretary Howard, did you have a comment? And if not, then I'll go to Senator McGinn.
I don't, but I think my commissioner, Andy Brown, might want to comment on that. I see he has his hand up.
Andy?
Yeah, this is Andy Brown with KDADS. And I do want to say that employment is one of the kind of the key pillars of making sure that we have appropriate behavioral health services in this state. And it is a primary protective factor against suicide. So there's really, when you look at Joyner's theory on suicide behavior, what really impacts suicide attempts is a combination of three things, which is sense of purpose, right, of hope, right? If you have a sense of purpose and hope, then you're less likely to be suicidal. If you have a sense of burdensomeness, which would be, you know, in the case of somebody who may have critical health issues or are unemployed, if they're in a situation where they feel like they're a burden on others, they're more likely to be suicidal. And then the final component of that is that they have acquired means access. So access to means is really one of our primary suicide prevention efforts that's effective. And so that involves things like making sure that access to lethal means is something that is protected, and that we do our best to limit people's access to acquiring access to those means.
Senator McGinn.
So we have a document that says that we know 20% of the women committed suicide because of job-related reasons. How do we know that? How did you get that data? Did you get the data in the therapy room, or did we get the data after they had already committed suicide? And if we are capturing that data in the therapy room, what are we doing to guide them to get to a job? Because, you know, if you feel good and, you know, you're on steady ground, you know, you might know to go to the Workforce Alliance, or you might know to go to somewhere that's in your community that will help you get a job. But if you're sick and you're having a hard time getting off the couch because you can't get a job and you're depressed. So if you know, I guess I'm just going to go back to that original question. How do we know that 20% of those people committed suicide because job related, the therapy room, or after they already committed suicide? And what can we do if it's a therapy room to help them get to a job?
You want to take that, Andy?
Sure, this is Andy Brown with KDADS again. And so in answer to your first question, we do what are essentially psychiatric autopsies, right, for suicide. And so coroners will collect information, and then that'll be reviewed. KDHE pulls all those vital death statistics together and then reviews them and prepares those reports. So when we know, for example, that you know, what the means were, or you know, what factors were involved in the psychological aspects of the attempt, and then we do a lot of studies with people that have survived their attempts in order to help understand what their motivations were as well, which is part of the reason why that body of evidence exists. And then we do work in mental health, especially within the CMHC system, around things like supported employment. So supported employment is essentially a program that allows for individuals that may have a hard time otherwise obtaining and maintaining employment to receive things like on-the-job coaching, support with training, those sorts of things. So we do a fair amount of that. I think it's fair to say that we could certainly do more of it. And I think that it's also really sort of incumbent on the system to make sure that those services can be available in communities around the state, whether that's through telehealth or through other services in a community outreach method.
Senator McGinn.
So you said you do some support in employment and training, but I think about individuals that maybe are a low wage earner, did not have the opportunity to go to any kind of extended education or training. They may not know what their skills are. And so I'm wondering if somebody came into somebody's office, if there was a way that we could, I'm sure there's something out there, we have to get it figured out and coordinated, but to help them understand what their skills are so that they could get them to a job that they could be successful at, and a job that they would enjoy. So, I think that's part of the problem too. If you're only making $8 or $9 an hour and you're doing something you don't even enjoy, I think it's important that they may have a skill that they don't even know they have. And so I think identifying job skills of these individuals to help them get to a job that's going to be sustainable for them for a long time. Thank you, Madam Chair.
Did you have anything to add to that, Andy?
This is Andy with ks, and I would respond, like, in a nutshell, you're describing what supported unemployment is. And also the important thing about jobs, regardless of what level that they reimburse people for their time, is that jobs provide both a sense of purpose and a sense of community. It makes people feel like they are connected to others in their environments. And that's really kind of one of the major critical components. It's not always about what level of income folks are making, but it's more about whether or not they feel like they're connected to others and that their efforts are important.
Any further comments? Back to KHR.
Thank you, Madam Chair, and thank you for that discussion. So now I'd like to invite Kyle Kessler from Working Group 3 to present their update.
Madam Chairwoman, can you hear me?
Yes.
Okay. Thank you. And I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers and the Chair of the System Capacity and Transformation Working Group. Our first meeting was held on September 18th, and the general barriers were discussed in the crosswalk relating to law enforcement, working closer with mental health professionals in the field, workforce shortage, again, as a reoccurring theme, working across systems, reducing access barriers, and lack of a strong infrastructure, cost prohibitions for treatment, and the need to improve integrated care, as well as the rural and urban divide, and the need for a mental health hospital in South Central Kansas. Data system and interaction with legal system and law enforcement were two that were prevailing themes for discussion. On the data system, the barriers were engagement and interaction of health data exchange and needing more connectivity, and competing exchanges like Lacey and Cahan, cost prohibitions and the ability to actually input data. How do we bring law enforcement into this? How does confidentiality work when bringing in an outside agency? Electronic medical records also, as were discussed previously, and needing parity between behavioral health and mental health when it comes to electronic medical record systems. That references, I believe, in regards to previous federal legislation that allowed for additional funding for health information technology, but excluded behavioral health for several years. And I believe now there are grants available for that. Lack of funding, and then the direct service electronic health records at state hospitals being extremely outdated. And then there were discussion at that meeting about bringing in supplemental experts, which included Laura McCrary from the CEO of the Kansas Health Information Network, and Chris Schwartz from KDHE Medicaid. Then in the area of interaction with the legal system and law enforcement, barriers that were discussed included the need to look at the legal framework and the state's constitution. Also, a lack of housing supports for high acute individuals being discharged, and non-restorable children interacting with the juvenile justice system, and also mental health within the court system. The additional conversations were about the system transformation and telehealth. Barriers in system transformation included some of them that were actually discussed in the crosswalk as well, like cross-system collaboration, treating people in the court system the same as anyone else when it comes to cost, infrastructure changes, and again, back to integration of care, as well as the lack of capacity and the need for a regional residential facility in South Central Kansas, and workforce development, and also Medicaid payment structure with parent support only available when the child is the primary client, and the need to support families through the system of mental health. Some of the supplemental experts that were discussed included Representative Bishop mentioned Sharon Feaster and Robin Chadwick from Via Christi, and then Joan Tamity from ComCare. On the telehealth issue, barriers that were discussed included the impact of COVID as a trial run and increased access to services, but there are needs which were not met, and the need to define the telehealth network in Kansas. Also, the need to examine age limits in utilization of mental health, as well as the system transformation and treatment within jails using telehealth. I think you'll hear about several of those items actually this afternoon with presenters. Also, lastly, the originating site need to look at what we want to be able to offer within CMS guidance, where it makes the most sense to patients. And supplemental experts, I had mentioned David Jordan, the CEO of United Methodist Health Ministries Fund, as they have just embarked on a huge survey and study of telehealth policies amongst provider networks around the state. That was essentially what we discussed in the meeting on September 18th. And if I can move to the meeting where we discussed in more detail some of those items, that was held last week on Wednesday, September 30th. So a couple of decisions that were made initially were to remove the following recommendation from the list to be studied. That recommendation was about the Child Welfare System Task Force, and was a Tier 1 recommendation, which was that the state of Kansas should create a single cross-system web-based integrated case management and data reporting system that can be used by DCF and all relevant agencies and stakeholders to efficiently and effectively share information, including education, dental, medical, and behavioral information. The decision to not pursue this recommendation for study or discussion was for a couple reasons. The primary one being that the current foster care oversight committee would appear to be the best place for that conversation to occur. And since there were enough other things on the working group's list to discuss, and one somewhat related to this, the decision was made to go in this direction, which was to look at, which was also from the Child Welfare System Task Force, but it was related to information sharing also. And so the original recommendation was that the state of Kansas should establish a multidisciplinary approach and share information across and among stakeholders, irrespective of state borders, in accordance with federal and state laws. That was revised to say to utilize Medicaid funds to provide incentives to providers to participate in health information exchanges, such as Lacey or Cahan, and which would also incorporate a demographics recommendation to be looking at location, both things like urban and rural, diversity, race, age, gender, other factors, ancestry, and language, English as a second language. Also, the information that was defined to include medical, behavioral health, and primary care. Define stakeholders to include primary care, primary provider of services such as CMHCs, FQHCs, primary care physicians and pharmacists, and courts. Barriers that were identified included organizations, providers who have no digitized record, also being a cost barrier. The discussion also occurred relating to Cahan and Lacey and education and training being critical due to workforce turnover, and it's important to keep participation at front and center with providers, and the challenge about not mandating participation in Cahan. The ease of implementation was seen as an 8, the potential for high impact was a 9. Some of the conversation that occurred between or amongst participants was the importance of utilizing health information exchange, but then on the other side, if you mandated it, would you potentially chase away certain providers or small providers in behavioral health who didn't currently have access to digitized systems or electronic medical records? And if we chase away any providers, then that will make an already a shortage of workforce that much worse. Crossover your youth working group also was part of the discussion here, the recommendation relating to demographics, as I mentioned earlier, and figuring out a way to share the statistical data with law enforcement, even though they wouldn't be on the health information exchange. That's something that could occur through local providers in cooperation or collaboration with their law enforcement folks. Excuse me. The following recommendations will be combined into one. So the Governor's Behavioral Health Services Planning Council Subcommittee, encouraging state agencies to develop policies that improve their ability to access and review cross-agency data for making service and program decisions based on a thorough shared needs assessment, integrate and utilize the guidance of a state epidemiological work group, enhance data collection procedures, change legislation regarding public behavioral health and youth surveys. For example, the Kansas Communities That Care student survey and the Youth Risk Behavior Surveillance System from an opt-in consent to an informed opt-out consent to allow for meaningful data collection and availability of data decision-making. Also from the Governor's Behavioral Health Services Planning Council, reverse the active consent policy that currently requires active parent consent on the Kansas Communities That Care survey, and explore options to report county data about substance use, treatment, access, and outcomes to agencies in order to aid in strategizing local and state response to addiction. And then the same type of recommendations had come from the Governor's Substance Use Disorders Task Force from 2018, and included Kansas Communities That Care survey again, as well as collecting, analyzing, using, and disseminating surveillance data to inform prevention efforts and monitor trends in at-risk populations. So that's all data related. New recommendations based on identified barriers include the electronic medical record at state hospitals being outdated, and KDED's reported that they were in process of sending out an RFP, which will also look at replacing the KCPC system on the substance use disorder side, as well as, and the group recommended that a new EMR support automated Medicaid eligibility reinstatement, as well as interoperability with other systems as appropriate, such as the Medicaid eligibility system. Again, there was some additional conversation relating to replacing the KCPC system on the SUD side and including it in the state hospital RFP. So our upcoming meetings have yet to be determined, but that's a summary of our work, Madam Chair.
Any questions, comments? Must have done an excellent job out there, Kyle. I'm not sure how, but.
Well, we were the wonkiest of the wonky groups.
Well, I think one of the things that, and correct me if I'm wrong, but what I heard was lots and lots of money.
There were certainly there were funding conversations. Yeah, no doubt. I think that in terms of the health information exchanges, some of that's even awareness related, because it's not cost intensive to be on the health exchanges, but the costs up front would be more about how we can incentivize smaller providers to adapt an electronic health record if they're going to be Medicaid providers. So then that's one of the big pieces, but other ones really dovetail, I think, with the workforce conversations. And then I think that one of the recommendations that would have been considered by our group was probably, and I know the governor's or the Legislative Mental Health Task Force and the governor's Substance Use Disorder Task Force would have been that communities that care piece, and making that survey and opt out, especially again with the youth suicide problem and what has been measured about that in the past. I don't think have gotten nearly the volume or quality of data on that since it was made an opt-in, which I believe was about 8 or 9 years ago.
Automatic opt-in?
Well, that would make it an yeah, so it would be an opt-out, but an educated opt-out, that conversation, I believe, and I know for sure that Deb Stidham, who's on this in this meeting, knows more about this than I do from past experience. But an educated opt-in would be able to tell parents at the enrollment point, here's a survey that kids take. Do you want them to opt out? Right now, there is a lack of information on the survey to allow them to opt in, especially if you don't have access to those caregivers either at the enrollment point or parent-teacher conferences or other engagement.
Was that something that was done here in the last 2 or 3 years to change it from opt?
I think it changed from an opt-out to an opt-in. I want to say it was 8 years ago, Madam Chair. It might have been 7. I think it's been at least 7 or more. But yeah, that there was legislation that passed out of House committee last year, but didn't get to the floor. But there have been bills introduced the last couple of years.
All right, I'm probably thinking of a different program. Questions or comments for Kyle and that working group? Anyone on Zoom with a question or comment?
Deb Stidham, Madam Chair. I'd like to make a comment.
Yes.
I just want to follow up on Kyle's remarks about the prevention survey. And I'm not really, to this day, I'm not sure what the impetus was for the change with that, why that legislation was perceived to be needed. And maybe it was for some other context. But I can tell you that Kansas had one of the most robust prevention data survey systems in the country. And that had existed for probably about 30 years, I believe, when that law changed, and it dramatically impacted our ability to kind of survey our youth and make targeted interventions at the local level, as well as the state level, to address those local needs. And so that's certainly something that does not have a cost factor that could be done fairly easily should the will exist to do it.
Thank you for that. Other comments, questions?
Yeah, this is Kathy Bush, State Board.
Go ahead.
Thank you, Madam Chair. Yeah, the opt-in, the School Mental Health Advisory Council has taken a position that we would like to see that go from an opt-in to an opt-out as it was several years ago. I think Kyle's probably about right. It's probably 7 or 8 years ago that it changed. And at the time I was out of schools, but it had a real impact. You can see the dramatic impact that it had on the number of students that take that. More are starting to take it again. You see the numbers slightly going up, but we've had a lot of in-depth conversation at our advisory council. And the folks from Greenbush who work on that survey came and presented a lot of information to us. It is excellent information, can provide a lot of resources for grants and so on that just is not as available as it used to be. So the School Mental Health Advisory Council is certainly going to go to the state board and request them to take a position on that also. So we'd like to see it go. I like the terminology informed opt-out, but we'd like to see that be a change, and I'm quite certain that has to have legislation to do that.
Thank you. Other comments or questions from other members on the Zoom? All right, seeing none, we're back to Kate Chai.
Thank you, Madam Chair. Hina, Shaw KHI. Again, I'd like to take kind of the 5 minutes to think through data systems. And we've heard a lot of keywords like interoperability, you know, do all providers have EHR accessibility? You know, what would it take to modernize our system? And so I'd like to take a few minutes to say, what will data systems look like in a modernized behavioral health system in Kansas? What are some high level goals or desired outcomes? You know, what are we dreaming for?
I think we're ready to move on. Does that completes your information for us this morning?
Yes, unless the working group has any comments about any visions, any visioning for data systems, or any input from the special committee, I think that will conclude our session.
All right, thank you. Committee, we're going to go ahead and move on to the next item on our agenda, which is a presentation on the crossover practice model, improving behavioral health services and outcomes for crossover youth. And we have Shay Belchak. Did I pronounce that right?
Yes, you did.
All right, thank you. Welcome to the committee.
Thank you. And it's a privilege to be able to present to the special committee. My name again is Shay Bilchik. I'm not sure how much background information you have about me. I'm a lawyer by training. I worked as a prosecutor in the state of Florida for 16 years before joining the U.S. Department of Justice, heading up the Office of Juvenile Justice and Delinquency Prevention. I've also, at one point in time, led the Child Welfare League of America before assuming my current position as a research professor at Georgetown University, where I am now the founder and director emeritus of the Center for Juvenile Justice Reform, a center I founded back in 2007. My career has largely focused on young people, kids in the child welfare system, kids in the juvenile justice system, and a particular interest of mine has been children who are involved in both of those systems of care. And that's largely what I'll be talking about today, focusing more broadly on the population, but also more narrowly on some of the behavioral health implications for this population of young person. Now, I understand that someone on site there is going to help me by advancing the slides as I go through them. Hopefully you have a hard copy of these slides as well as slides that might be up on the monitor. So you'll track along with me. On the second slide, the next slide, my agenda today is talk a little bit about our center and what we do. That will be very, very, very brief. And then focus primarily on this population of young people, their characteristics and the outcomes that we see when we work with them. How we have developed through our center at Georgetown a multi-systems approach in better meeting their needs. And then some of the outcomes that we've seen resulting from the CYPM or crossover youth practice model implementation. I'll also, as part of that concluding section, talk a little bit about what's happening in Kansas in relation to a state policy team focused on this population. The next slide focuses on our mission. Again, I'm not going to get into great detail. You'll have this as a resource slide. Then the next slide talks about the range of things we are involved in at our center. And again, I'm not going to focus on this material, just leave it with you as a resource. And if you have any follow-up on it, you can contact me independently. The next slide begins the section on the national research on crossover youth, their characteristics and outcomes. Going on to the next slide, you'll see the social ecological model or the nesting theory. For those of you who may have studied social work, this may not seem unusual, unfamiliar to you. Yuri Bronfenbrenner really came up with this type of social ecological model. And largely our juvenile justice work in this country is based upon the foundational work that Bronfenbrenner did, even though he did it in relation to social work, not necessarily juvenile justice. In this nesting theory, he posits the notion that if we are really going to impact the trajectory of a young person's life, we need to think about the domains of their life where they nest, where they live. And then he creates, or I've created a depiction of that, as communities are one dimension of that. The schools the children are in, another. their peer group, their families, and then their own individual characteristics. All of these dimensions are dimensions that we need to make sure are strong foundational pieces of a child's life in order for them ultimately to be successful in life. When we look at our assessment tools we use in juvenile justice these days, including the ones in Kansas, they are largely predicated on these domains. You know, is there a school dynamic that is going awry for a child? Are they hanging out with a negative peer group? Is there dysfunction in the family setting? Is there abuse and neglect? Does the youth have individual characteristics that leave them more likely or risky to engage in delinquent behavior, aggressive behavior, antisocial behavior of some sort? So those are the foundational pieces. And I wanted to mention that because I think when we do work in our systems of care, including child welfare and juvenile justice, we need to spend a lot of time thinking about what I'll call as well-being indicators. And this is one of the three basic core elements in child welfare practice: safety, permanence, and well-being of our children. But oftentimes we spend a lot of time on the safety and permanence dimension, which is important, but not an equal amount of time on, is this child having their well-being needs met while they're experiencing this negative dimension to their life, whether it be in the peer group, the schools, or if they're in the child welfare system, how they're experiencing that system. Moving on to the next slide. I want to talk about crossover youth, begin to narrow it down to this population. There's lots of different ways we can define crossover youth. The broadest definition, the outer ring of this slide, is any youth who would have been abused or neglected and also got involved in some delinquent behavior, whether we know about it or not. In a technical way, they are also a crossover youth. Their life outcomes will be impacted in a negative way because of those behavioral dimensions to their life. But there are also other definitional pieces to dually involved or crossover youth. And so while there's multiple dimensions depicted on this Venn diagram, I want to go to the next slide where it gives you the definitional pieces to that Venn diagram. And I want to focus specifically on dually involved youth, because we can have youth who have been involved in the child welfare system, involved in the juvenile justice system, but not at the same point in time. And that's what a couple of these different definitions depict. Those are important things to know and understand, and indeed may increase the risk for negative outcomes for a child. What we largely have focused on in our work at Georgetown is the dually involved population. So these are youth who are referred for an investigation on the child welfare side and or have involvement with both the child welfare and juvenile justice systems. So when there is this dual involvement, what we are suggesting is that these systems need to work together in a way that historically they have not. Historically, they have been more siloed. The next definition is duly adjudicated. And I want to mention the distinction here. So if we're talking about dually involved, it would be a child necessarily who comes into the child welfare system. There's an investigation finding neglect, and there are family services being provided. While those family services are being provided, the young person gets involved in some delinquent behavior that is detected. So there's an intake taking place on the delinquency side. That's dually involved. The involvement is at the very beginning stages, right? It could be voluntary services in child welfare based upon that neglect investigation. It could be a diversion on the juvenile justice side. But the fact that both of them are going on at the same time is a warning sign that we need to pay attention and understand what's happening in this child's life. Are those well-being indicators somehow going awry beyond perhaps the family dynamic? And what can we do to pay attention to that? Duly adjudicated would be youth who are fully adjudicated in both systems. So they not only have been referred on an investigation in child welfare, they have gone through the voluntary stages. They've been removed from home and adjudicated dependent, but also on the delinquency side have been arrested, intake, put on probation as an adjudicated youth. While that population is certainly an important population to focus on, we don't think you need to wait for dual adjudication. We think the systems need to respond differently right at the dually involved stage, and then work together in a way to meet the needs of that child and make sure that both they are safe and the public is safe. So moving on to the next slide, I want to start talking about the demographics of this population of young people. It will highlight some of the things we need to begin to pay attention to in relation to the population. So first of all, there's an increased likelihood that girls will cross over at a higher rate than boys. So as an example, nationally, girls represent 29% of juvenile court cases. My guess is that this is similar to the percentage in the state of Kansas. Yet when you look at girls in the crossover population, it is anywhere from 30 to 50%. So there's something that's happening. Now this crossover is occurring moving from child welfare into the juvenile justice system. And that is about 85% of the crossover we see nationally, that's the flow of the crossover. There's also crossover from juvenile justice, a referral into child welfare, but this is the dominant pathway. What this means is that girls in the child welfare system somehow are having their involvement, their experience is accelerating their movement into the juvenile justice system at a higher rate than kids who girls who just come into the juvenile justice system without any child welfare experience. This is also true for African-American young people, where we see that they are overrepresented in the child welfare system in and of itself. They are overrepresented in the juvenile justice system in and of itself. But when it comes to the crossover population, the overrepresentation is even higher, which means that given the overrepresentation at a base level, something is happening in the care of African-American children that might be, again, accelerating their movement into the juvenile justice system. So if you put these two bullet points together, if you are an African-American girl, and this is a national statistic, I think it will hold true in Kansas as well, you have the highest possible rate or probability of crossing over from child welfare into juvenile justice, which is a warning sign that we need to take a look at what might be happening that might be driving that phenomena. We also see this higher proportion for LGBTQ or gender non-controlling youth as well, GNCT, I'm sorry, non-conforming youth. Going on to the next slide, we see the child welfare involvement profile as well. Histories of physical, sexual, and neglect are all related. So we know that if you are abused during adolescence, it's as equally or maybe even more so related to crossing over than when you're neglected or abused as a young child. This was counterintuitive for us when we started doing this research. We thought that kids at an early age who were abused and neglected, and that abuse and neglected was maintained into later years, would cross over at higher rates than adolescent alone abuse. And that's simply not the case. For those of you who work in these areas or have experience in these areas, it makes sense that an adolescent who may not have had any prior experience in the child welfare system, who all of a sudden is referred on an abuse case, is found to have been abused, is removed from their home, may actually struggle with that more severely than a young child who may actually adapt to that phenomena at an earlier age. In any event, this is the first sign we begin to see that there could be some behavioral health indications that begin to arise, and I'll be talking more about that with this population. We also see that young people who are placed in congregate care or out-of-home care also cross over at higher rates. So to delineate here in a tiered manner, a young person in the child welfare system who's cared for in their home with wraparound services has the lowest likelihood of crossing over. If they are placed with a foster family or a relative caregiver, the next higher level of probability. But when they are placed in a group facility of some kind, a residential treatment center or a group home, that is the highest possibility or probability they will cross over. Lots of reasons for this. If we had more time, we could discuss it in greater detail. But one is a contagion factor, that when we take a young person who him or herself is struggling and put them in a group setting with other kids who are struggling, there can be that contagion factor taking hold that may be accelerating their negative behavior. Frequent placement changes. When kids are moved in placement, it increases the probability that they will cross over. Less likely to form pro-social bonds with peers and adults. This is partially they're removed from their home, which oftentimes means they're removed from their school, lose their friends, lose their favorite teachers, lose their extracurricular activities, may lose contact with their parent who is not abusive in terms of frequency of contact, losing contact with a lot of the pro-social influences in their life. And then they're more likely to have longer stays in child welfare when they cross over than children in child welfare who do not cross over. So moving on to the next slide, we'll talk about some of the psychosocial, which really gets to more to the heart of the work of the special committee. So we see through Durkhuizen's work in 2018 that 31% of a sample of 718 crossover youth in Los Angeles had suicidal ideation or attempted suicide, a much higher percentage than you see in the general population. They also had higher levels of substance use than justice-only involved youth. So kids who crossed over again, child welfare, concurrent involvement in juvenile justice are demonstrating higher levels of substance abuse, and these two data points support that. More likely to have mental health challenges. Dr. Denise Hers out of Cal State LA in 2018 found that 75% of crossover youth in LA had a diagnosed mental health disorder. What I want to say here, in addition to what you see through the research through Hers and Durkheising, as well as Halemba, is that in our research at Georgetown, in all the sites that we've worked with, this is a common dimension to the profile of the young people we see. That there are behavioral health challenges that are far higher levels than kids in the child welfare system or juvenile justice system alone. As a common data point in the sites we've worked with, 83% of the crossover youth have a diagnosed mental health, substance use, or co-occurring disorder. And that is an extraordinarily high figure compared to what we see both in the general population, but in the population of young people in the juvenile justice or child welfare systems individually. This next bullet on the familial mental health and substance histories is almost a given, that a lot of the source of the abuse and neglect may come from the mental health or substance use histories of the family themselves. And then also we see that the most common psychosocial related causes for inpatient hospital care for crossover youth are mood, psychotic, attention, and conduct disorders. That was a study done out of New York. The next slide highlights some of the juvenile justice involvement issues. And I want to present this as a whole, because I think what we're seeing here is that while this population is not necessarily involved with extremely serious violent behavior, they tend to be treated more harshly than children who are alleged to have committed similar acts of delinquency. So while this first data point shows that less than 1/2 are charged with violent offenses, most of those violent offenses are minor violent offenses. They are a simple assault, a simple battery. A lot of these are also incidents in the group homes or at school where there's destruction of property. A lot of the contextual situations that children find themselves in that are frustrating and that they begin to act out around. Even though we see that the behavior itself, and by the way, I want to pause here to make clear, this does not mean that there aren't crossover youth who are charged with extremely violent behavior, where there might be an armed robbery, a home invasion, burglary, a sexual assault. All of that does take place. It is the extreme minority of offenses for crossover youth. The majority are as I've described. Yet they are detained at higher rates than non-child welfare involved youth. So lots of reasons for this that are depicted in this slide. Someone may not be picking the youth up. A caretaker refuses to have the youth return to placement. They don't know a place to release the youth to, and Children's Services is struggling to find one. They are also less likely to be considered for diversion. So two similarly situated children in every regard except the child welfare involvement, no prior history, minor offense of theft, shoplifting, let's say. The crossover youth, the youth coming from child welfare, often is viewed as having more serious, complex issues because they were quote unquote in the child welfare system. They were abused, they need more services. So they're not given the same opportunity for diversion and instead brought into the juvenile justice system, which exposes them to the risk of violation of probation. And for kids who are struggling with having been abused and neglected, having been removed from home, maybe having lots of placement changes, changes in school, a lack of school stability, struggling with education, they tend to act out. They tend not to be the most conforming youth in terms of their behavior. It's not to excuse it, but it's to explain it, and also to understand that there's no reason they could not go into diversion, being supported in the diversion plan that's been constructed. And indeed, that's what we've done in a lot of our sites that we worked with. Again, in juvenile justice side, also more likely to receive out-of-home placement. And by 1 year, they are typically younger at the age of their first arrest than youth not involved in child welfare. So that means the delinquency career of a young person in child welfare starts 1 year before, on average, the juvenile delinquency career of a child who's not been involved in child welfare. So there are accelerants that are going on, whether it be the broader range of family, school, community, peer group, or the individual characteristics that are impacted by the abuse and neglect, and then the system involvement that follows. I commented directly a little bit on education, low levels of school connectedness, high school mobility, truancy. You take a child, remove them from their home, also change their school, move them and place them again, change their school again. And we begin to see a lack of connection to school, actually a lack of hope that they can succeed in school. So they begin to get frustrated, are having a tough time keeping up in their education, and they begin to act out in the school environment. The behavior of a child who is not prepared, hasn't been able to focus on their homework, get ready for a test, is to generally begin to act out in the school setting. The second major bullet here about the Legal Center for Foster Care and Education estimated that at every change in placement, a young person loses 4 to 6 months of academic progress in school. Now, I want to make this clear. This is not a change in school. It's every change in their placement where they're living, they lose 4 to 6 months of academic progress. I'm sure many on this special committee, staff members in the room or on Zoom, have experienced a change in where you live. You were moving, you move from one community to another, maybe one school system to another. There was always this concern about how will I do in my new school? Will I make friends? Will the academics be more challenging than I'm able to deal with? The fear of a parent for a child, will their child be able to succeed? These children, in the worst of circumstances, without a lot of the supports that we would naturally have, experience these changes of placement and are unable to keep up with their academic progress. And when there are multiple changes in placement, often with the additional exacerbating fact of changes in school, it makes the situation even worse. And then this last major bullet that we see a lot with this population is they have an increased chance of qualifying for special education, and then also difficulty accessing appropriate services. Going on to the next slide. Recidivism rates are higher. I'm not going to spend a lot of time here. We see that they're more likely to recidivate in both the juvenile and adult justice systems. This study from CIDI in New York examined recidivism and subsequent placement of crossover youth, both in adult jails and state prisons. And we saw these negative long-term outcomes taking place. And then we also see a longer history involved with child welfare alone, increasing the likelihood of recidivism, which we know is the characteristics of the population. If you think about this in the totality of what I presented so far, you can see that what we're really talking about is an intergenerational phenomenon. That if we don't kind of nip it in the bud, if we don't address this population as soon as they become duly involved and begin to work together as collaborative systems in assessment, planning, and management, we see the long-term trajectory unfolding the way I've described in these slides. And then also those kids becoming adults who become the parents of the next generation of kids in our child welfare or juvenile justice system. This next piece about, on the next slide, access to service, is from Dennis Culhane, who examined the discrepancies between service referral and then access for crossover youth in Los Angeles. Again, a very important dimension for your work in Kansas. 74% of these kids were referred to individual therapy, but only 55% were managing to access the service. So is this a product of not having the service available? Was it a product or byproduct of the service not being easily accessible geographically to where the child and family lived? These are obviously individual things to study in a particular jurisdiction. In terms of academic tutoring, 43% referred, only 17% accessing. And for medication monitoring, considering the severe psychological issues many of these children face, 33%, less than half though, accessing services. Just 50% of those youth prescribed a psychotropic medication were found to actually take their medication. So again, lots of reasons for that. Did they actually pick up the medication? Were they supervised by a responsible adult to make sure they were taking the medication? But all of these access to service pieces, particularly the first and third bullet, should be of concern if you analyze them in the state of Kansas and find that when it comes to behavioral health needs of children, we need to be thinking about the access issue as an important piece. Then this next slide on public service utilization addresses the issues about the long-term costs of not addressing this population as early as we can and as effectively as we can. They are involved with public services. This is a study that Culhane did, as well as by CIDI of New York, that in these three bottom bullets, 94% in New York City, 80% in LA, of crossover youth utilized at least one service in a 1 to 6 year period, 80 and 78% respectively, 2 or more services, 49% in both New York City and LA utilized 3 or more services. So we once had a site we worked with in Colorado. It was a small rural community. And we talked to the judge there about whether he really wanted to make the effort to adopt the crossover youth practice model. But our guess was he had very few of these young people in his community. He said, Shay, that the truth of the matter is I only have about 10 to 12 a year, but they are my high flyers. We have calculated they cost us over $1 million each in the life course of what they do in terms of reliant on public services, incarceration, involvement in our child welfare system. So we want to figure it out earlier in time. We want to understand what to do to get them on a better trajectory, a more positive trajectory, and not see them fail in life, but also be a cost burden to our systems of care. And then this again is a financial impact statement out of the CID I work in New York City, showing how much more expensive it is for crossover youth, accumulated costs. So the next slide, I'm sorry if I'm not guiding well enough. I'm going to move on to a multi-systems approach, slide 18, the crossover youth practice model. And I'm going to save questions for the end so we can get through all the material, and then hopefully we'll have time to answer your questions. But I know I'm putting a lot of material out to you. So moving on from the multi-systems approach slide, this next slide talks about the system challenges to improving outcomes for our young people. And I've created 3 basic categories here. One, that we're not doing enough around preventing crossover. There are certain requirements, a group home provider under their contract must call the police when the youth is involved in any type of delinquent behavior in the group home. This is the kind of systemic regulation that sometimes can lead to crossover when in other situations, other communities that don't have those kind of policies, they're able to de-escalate the behavior. Maybe call the police, but not have the police arrest and remove the child. Also a failure to identify needs and risk, that well-being dimension that I talked about earlier. Are we really assessing kids early on to understand what that child welfare involvement is doing to their well-being and what some of the other behaviors might indicate in terms of risk and the needs they have that we need to meet, and then make sure the adequate supports are being offered. On the information sharing side, we need to communicate across systems in order to identify behavioral health needs and plan to respond to them through interagency collaboration. So I'm going to move on to the next slide and the phases of practice in the crossover youth practice model. So this is a very bare bones description of the model. It's broken into 3 phases. The first phase is when a youth does cross over at the point of arrest, so they're involved in child welfare, they've been arrested, are we able to identify them as a crossover youth? Are we able to actually communicate between the law enforcement or intake function and the child welfare caseworker that this young person has been arrested? We understand that they're in the child welfare system. Let's begin working together to make sure, 1, they're not detained, and that we're making an appropriate decision regarding charges. Should this case be diverted? Should the case be moved on into the formal system? And this is a big blind spot that occurs in many communities where the 2 systems are operating in silos, and only inadvertently at some point in time later do we learn that the young person actually was duly involved at the point that they were arrested. Once we are able to undertake that stage, whether they're diverted or whether they come into the system, make sure there is a strong joint assessment and planning process. So this involves the child welfare system, the juvenile justice system, behavioral health, education, developmental disabilities, a wide range of folks who might have contact with this child and family to help us assess what are the actual needs and how will we plan to address them. Where are the resources? I heard as I came on a little bit early about, does this always speak to needing new resources? Well, sometimes it does when there aren't sufficient services, but sometimes it's about bringing all the partners to the table and determining how we can plan a case plan for the child that maybe child welfare provides one dimension of it, juvenile justice provides another, our managed care behavioral health partner provides a third. And together we can create a collaborative case plan that meets the child's needs, maybe within existing resources. Again, they may oftentimes be the need for more. Then third, during the ongoing case management, are the systems talking to each other? Are we consulting to see what how the child and family are doing? This ongoing assessment piece to make sure that if something is going off track, we come back together and determine why is it going off track, rather than the simple, immediate reaction of I'll violate their probation or we'll remove the child from the home again. How do we identify early on through coordinated case management the progress the child and family is making or the challenges they're experiencing, and how can we address them? And then finally, planning for youth permanency and transition out of the system in case closure. This is something we advocate, which is part of obviously the child welfare system, because permanency and is a key dimension of the three-legged stool they operate on. But we want it to be for both the juvenile justice and child welfare system, that they're thinking about what is the permanency, what are the sustained relationships, what are the supports this young person is going to have as we begin to close out the child welfare case as well as the delinquency case. That historically has not been part of how we view the juvenile justice system. So moving on to the next slide, documented CYPM outcomes. We see both reductions in some areas and increases in other areas. The reductions are reductions in recidivism in the justice system, a reduction in new sustained juvenile justice petitions, a reduction in the use of that pre-adjudication detention. And again, when I talk about detention, I want to be clear, particularly as a prosecutor for 16 years, we're not talking about not detaining kids who need to be detained for public safety. We're talking about releasing kids from detention who can be released safely, because we're doing a lot of the collaborative case assessment and planning and determining interesting and good positive ways to release the children from detention. And then reductions in the use of APLA, alternative planned permanent living arrangements, as a permanency goal. I know many of you are probably not familiar with child welfare, but when a child is not going to have a permanency plan of being reunified or a permanency plan of being adopted or going into guardianship, oftentimes they're given a permanency goal of alternative planned permanent living arrangement. And what this means basically is they are going to age out of the system. When we first started doing this work in our test sites, we saw rates of APLA of upwards of 50 to 60% in many of our communities. And that permanency goal has been dramatically reduced, both by new provisions in federal law, but also through the practices in our crossover youth practice model. So where are we seeing increases? We saw them in improved educational outcomes, higher academic performance, less truancy, less behavioral incidents in school. We saw increased pro-social activities for these young people. Oftentimes when they were removed from home and moved into a new neighborhood, they might have been involved in the YMCA or the Boys and Girls Clubs. And we were trying to work hard in our case planning under the model to make sure they could be reconnected to those pro-social activities in some way. Increase in positive behavioral health outcomes, as reported by the caseworkers themselves, by family members, and the young people themselves. Increased use in diversion, increased home placement and reunification that came from using the model, and increased social supports for these young people. So moving on to the next slide, I'm just providing a couple of external evaluations. The National Institute of Justice found the crossover youth practice model as a promising program, evidence rated as promising in these various program types. And then the California Evidence-Based Clearinghouse for Child Welfare also found the practice model to be designated as having promising research evidence with a rating of 3 out of 5, based on the aforementioned studies, with a high relevance for child welfare practice. And this is exactly where we at Georgetown wanted to be. We don't want the practice model to be seen as something that only applies to child welfare or only applies to juvenile justice. We thought that bringing the systems together would create this kind of collaborative best practice, which in essence it has. We're now doing this work in 23 states and 120 local jurisdictions. We did launch the practice model in Sedgwick County a number of years ago. And in a recent hearing in front of the Foster Care Committee, one of the officials from that county reported out on some of the good progress made in Sedgwick as a result of implementing the model. Going on to the next slide, I wanted to focus more narrowly now before I conclude on Kansas itself. So one of the reasons that we at Georgetown became involved again in Kansas on these issues was that there was a determination made to bring together the Office of Judicial Administration, the Kansas Department of Children and Families, and the Kansas Department of Corrections to work with a variety of partners listed on this slide to create a crossover state policy team to determine what are the state level policies that are needed in order to better serve this population, and then what are the practice implications that you need to follow in order to bring that to life in counties around the state. So you can see the partners here, including mental health and substance use, education, and I'm not going to read them all off, but if you think about the research that I presented and the practice model, you can see this is the cast of characters that need to be around the table in order to make better cross-systems decisions on how to work with these young people going upstream to an earlier point in time. The next slide is the vision statement for the policy team. I'm not going to read it, but I'll be a resource for you after the presentation today is over. The next slide focuses on the target population of the state policy team. So who are they focused on as crossover youth in Kansas? And this would be a young person age 10 or older with any level of concurrent involvement with the child welfare and juvenile justice systems. And it includes these varying ways that that involvement might be defined: out-of-home placement, probation, immediate intervention programs, voluntary preventive services on the child welfare side, et cetera. And the reason it's age 10 is because we want to involve the population that potentially could become a crossover youth currently. And that is the age of jurisdiction where a youth could come into the juvenile justice system. Next slide talks about the areas of focus of the policy team: information sharing and data collection. You can see all the key dimensions and the state policy development that will ensue, as well as support for pilots in local communities. So we're really interested in not just coming up with a set of policies that potentially could sit on a shelf, but while those policies are being developed, to actually implement them, as demonstrated on this next slide, in a couple of your counties. Shawnee and Montgomery counties were decided upon as 2 pilot counties. We also will go back to Sedgwick and provide ongoing support and assistance and quality assurance around their work as they move forward. So I think the hope here, not speaking for the policy team, but the hope here is that the demographics and geographic locations of these counties would allow for there to be an extrapolation that if we could do this work well in these counties, we probably can assume that we could do the work well in most other counties. But my guess is that once these 3 counties pursue the implementation of the model and are piloted, that there would be an iterative process to spread the model around the state with state policy guidance. But again, I don't want to speak for the policy team. This next slide is just one of the logos they came up with to try to depict what they're trying to do through the effort. And the next slide gets us to comments and questions. So I want to stop there. I hope that wasn't too fast, a presentation, and get back to you all and any questions you might have about the material that I presented.
Thank you very much for that presentation. It was a lot to absorb, and I think at some point we probably will have more questions than we do now. And I've documented some of mine. Do we have questions for him, committee members? How about on the Zoom? Okay, well then I'll go ahead and start off. And you may have answered this when we were looking at the access to service page, and I don't remember what page that was, but the question I had written down was, how often in the mental health, behavioral health treatment do we do meds versus non-med treatment?
Well, I don't have a data point for you in Kansas on that at all. Nationally, I think that there is a great concern about the over-medicating of kids with psychotropic medication as a little bit of an easier answer to controlling behavior. I don't want to, again, delineate between juvenile justice and child welfare. I think this is even a greater concern in child welfare with children who begin acting out, that we see the use of these medications. But it's also an issue that's prevalent in juvenile justice as well. I'm just don't have a percent there to give you a distinction between the 2.
All right. Well, I figured that was going to be your answer, but I just wanted to kind of get some confirmation.
Sure.
The next one that I have, and I'm not surprised on the information you provided on the change in placement. The question always comes down to how do we address, because a lot of times the reason a child goes from placement to placement to placement would be our runners, our fire starters, those are sexually acting out,
right,
etc. So then they get moved from place to place to place. Usually, and Secretary Howard can jump in if she'd like to, I think it's because we don't have as many foster care homes, individual homes, that are trained to handle these types of children.
Right.
So how do you address that?
So I'm going to answer in a kind of an iterative process. One is to know the data. So looking at the disruptions and being able to actually quantify what are the reasons for our disruptions. Now, pull those cases, analyze the reasons. Now, there are going to be some situations where disruption absolutely is going to happen. And there is behavior of injuring a worker severely, setting fire to the placement, where there may need to be a change in placement. What we find in our data is that there are some of those cases, but the vast majority of changes in placement disruptions are occurring because the children are burning out the workers. Even though they are placed there with the understanding that the provider is able to work with the youth with the diagnosis they bring, there is a fatigue that takes place with working with these young people who have behavioral problems. So I think when we do the work in a site, we want to sit down with the providers and say, when you have these situations occur, what is it that you need? What can we do to help you in this instance? So I'll give you a couple of examples of the way we've approached this. Now, working with the providers, working with law enforcement, who tends to be the first person called, the first entity called when this behavior, is exhibited, we came up with a situation, for example, in one community where they said, to any potential disruption, this type of behavior taking place, we'll get a response both from law enforcement that has been trained in crisis intervention. So they will only send an officer to a placement site that's been trained in crisis intervention, how to de-escalate, and our crisis intervention from behavioral health. So the idea of that with a caseworker, obviously, in child welfare. So the idea there is that working together, we're going to help to de-escalate the behavior. We're going to hopefully avoid the disruption in placement and be able to maintain it, which means we maintain their school assignment as well, the relationships they may have in that placement with some of the workers that are working well, some of the relationships they may be having with some of the kids as well. So we're trying to think about, like you would with a family member, what can we do, let's say relative caregiver, where a child is removed from their home and placed with a grandparent. And the grandparent calls the caseworker and says, he's just too much for me. I can't handle him. And so the caseworker would say, well, what supports do you need in order to make this work? Do you need some respite care? You need that once a week we find an alternative placement for 24 hours. By the way, in San Diego, when we did our work there to reduce disruptions in placement, they developed something called cool beds. When the group home provider was saying, this kid's beyond my control, I can't have him or her stay here anymore, they would say, well, what about if we have a 48-hour placement in a cool bed? Let everybody cool down and then bring the child back into placement. And that's what San Diego adopted as part of their protocols. So I think there are some situations, again, and you point to them, some of them that are more extreme, but the vast majority of disruptions we see are on a different playing field. They're for different reasons.
Okay, Representative Carpenter.
Thank you, Madam Chair, and thank you for this interesting presentation. In this business, we hear a lot of presentations and they get put on a shelf and we don't implement them, or what states have the best implementation rate and how do they do that? How do they monitor the situation and make sure that it's actually working?
You always get into trouble when you try to pick your favorite children, don't you? Kidding aside, we have a number of states that have done incredibly good work, and I'll explain, I think, what they've done to get there. And by naming just a couple doesn't mean there aren't more. But I want to do a couple that are, at least one in particular is geographically relevant to you, which is Nebraska. We began implementing, like we did in Sedgwick in Kansas, we began implementing in Douglas County in Nebraska as our first site, and then went on to pilot it in several other sites. What the state then did was to say, okay, we've got about 5 counties now that have experienced this. We've watched their implementation. We've watched them develop their cross-systems protocols about how they're going to assess, plan, and manage these cases differently than what they did historically. How they've addressed those main issues around prevention, for example, or information sharing, delivery of services and treatment. So when they got to that stage, their main 2 agencies, actually 3 in that instance, the courts, probation, and their Department of Health and Human Services came together and said, let's develop a set of state policies. And what is minimally required at the county level in our state in order to handle a crossover youth case. And so they developed that in consultation with a broader range of counties. They developed what the protocols they would look like, policies and protocols. They trained on the policies and protocols, and they set up quality assurance mechanisms to make sure that the work was actually unfolding the way it was supposed to. So they're about 2 years into this at this point. So we'd have to go back to them and say, you know, what are the things they've learned at this point from that? And by the way, we are in frequent contact with Nebraska, and my general impression is they're going very well. So the legs of that stool are, do you have policies and practices clearly identified? Do you train around them, not just one-time training, but ongoing pre-training, in-service training? Do you implement performance measures and quality assurance measures to make sure the work is actually unfolding? And this is exactly what we're bringing to the state policy team as to the construct of what makes a successful statewide implementation. There are other states that are going through similar processes. Arizona has implemented the model in all 15 of their counties. I know it's outrageous. They only have 15 counties in the entire state compared to so many other states that have so many more counties. But they did make a commitment to introduce the model and implement it in all 15. Similar thing, state policy level, training across the state, quality assurance and performance measures. So Missouri's doing the same thing as well. Again, we're in over 20 states, so I don't want to neglect any, but that's the basic construct of what helps to make sure something isn't sitting on a shelf, but instead is implemented and monitored and actually improved from year to year rather than see it denigrated.
Very good, thank you. Thank you, Madam Chair.
Another couple questions that I've got here is, if I understood your information correctly, is that kids that have gone through the foster care system versus those that were never in out-of-home placement but touched the criminal system, that the foster care kids are at a higher risk of becoming criminals. Is that correct?
That's correct. I think they're a higher risk of entering the juvenile justice system, which then challenges us to do two things. One, to make sure that when they are in foster care, that they have the supports they need. Their well-being indicator is as important as their permanency and safety indicator. And so they can have more of a positive youth development experience, even in that unusual life course situation of being in foster care. I do want to mention one other thing in response to your question, and then I want to mention the other dimension of it on the juvenile justice side. Going into out-of-home placement, foster care is kind of the deepest end of that, right? But even going into relative caregiver or foster families need the kind of supports that we're talking about. Any out-of-home placement increases the risk of moving into the juvenile justice system. The foster care in congregate setting is the highest risk possible. On the other side of the coin, the kids in foster care who get arrested, we need to make sure we're working with our prosecutors and probation staff on the juvenile justice side to understand that just because they have this experience doesn't mean that they are higher risk for delinquency. You know, let's give them a level playing field when they touch the front door of the juvenile justice system based upon their risk of delinquency, not necessarily some of the needs they have as a result of being abused and neglected. So I can create a diversion plan for a young person that says, we want the young person to understand that what they did was wrong and they're being held accountable for it. So they're going to have to do an X number of hours of community service. They're going to have to pay restitution if there's damage to property or whatever that might be. But we're also going to make sure we sit down with our child welfare partner and make sure part of our case plan moving forward isn't just the accountability side, but also meeting some of those more complex needs on the child welfare side. And actually, you know, one of the communities in Nebraska has done a beautiful job of setting up their intake on crossover youth to be a multidisciplinary team meeting that would create a diversion plan that would meet all of those needs. So I think that there's something on both sides of the equation here to be addressed, and also a mindset to change that it is not inevitable that these kids, because they're abused and neglected, are going to end up in our delinquency system or move on to our criminal justice system. We have the power of changing the way we do the work to put them on a different life course.
Committee, further questions? Senator Allen.
Thank you, Madam Chair. On slide 13, middle of the page there, you mentioned that if a child is placed in a home, a child loses 4 to 6 months of academic progress in school. And if that child is then placed in another home, they'll never catch up.
Yeah. I don't want to be fatalistic about that, but I want it to be a warning sign that when a young person is removed from their home and moves into not a home placement, even if they stay in their own school, their challenges around learning become increasingly difficult. The instability in their life, will I be able to return to my home? Will I ever be with my parents? Will I ever be with they're separated from their siblings, ever be with my siblings again? The mindset, the distraction for them to then stay on track with their homework, be able to study for their tests, be that optimistic, positive viewpoint, or have that viewpoint that we want kids to have in school, becomes challenging. So what has to happen with the very first move is we need to understand who those kids are, respecting the privacy interests. We need to understand who they are, and certain individuals in the school setting need to know what additional supports they may need to provide to help that child succeed in school. That's their lifeline. If they don't have that lifeline for education, they really are going to be challenged in their life course. But we can, with appropriate information sharing, again, respecting the privacy interests, we can share information with designated people in the school that could be there to support them in their studies, getting their homework done, making sure that psychologically they're ready to learn. And I think that's part of the challenge we have in partnering with our education partners to make sure that that's being done.
Yes, Senator Allen.
Thank you, ma'am. Not very many good things have come out of COVID. However, one thing that might help here would be the virtual schooling. And would it be possible that once a child is placed in a foster program and moved from their first school to a new school, that they take this courses in a virtual program and not in a placement in another school, where they might lose six months or more of training?
I love the creativity and innovation you showed in that question. I think COVID and what we've had to do to adapt has shown us there are a lot of things we can do differently, even in a post-COVID environment. And so I will take that as an idea back to my staff and talk with some of our sites about, can we actually imagine some telelearning for kids back to their home school that would allow them to have that continuity of teachers and classmates in a obviously different setting, without having to go and venture into a brand new school setting, particularly if the out-of-home placement may only be for a number of months rather than for a number of years. So I will take that as a placeholder issue, but I think that is something that should be explored. It would be challenging if no one else is doing the telelearning and this child alone is, but it might be something to talk about and figure out if it's possible to do.
Thank you.
Yeah, and something, we might want to think about, Senator Alley, is JCAC or KJAC. Jack, there we go, Jack, whatever. That exactly is what that program does, because you can have a child that was in Wichita but gets transferred to, they follow them, that computer follows them, and so they continue with that continuity. So we already kind of have a model to take a look at. So I think you're on target with something there.
Yeah, I'm glad you mentioned that. I had known about that program and forgot. So yes, that would be a perfect resource to talk about how do we enhance the continuity from what we're doing now. And I know that they would like to do even more than they currently are doing.
Well, we have, let's see, who is it? Chuck Knapp that heads that up here in Kansas, and they do a phenomenal job out of Topeka here with that program. It's really helped a lot of kids. Are there further questions or comments?
Madam Chair, this is Secretary Howard. I was just going to build on what you were just saying. I mean, because we have worked with JAG and a couple of other entities, primarily focused on credit recovery. I mean, if a student has moved around, helping them to still graduate on time through credit recovery. But we have had some dialogues with Department of Education over the course of the last year as well about the possibility of a broader virtual school. And this was pre-COVID as it relates to our youth in foster care. So the only other thing I was going to say is I was just going to offer remember that it might be helpful to the committee if we added to the resource page for the committee some of the other testimony that was done in the Child Welfare Oversight Committee when Shay testified there as well, in terms of some updates from DCF and from corrections, juvenile services about the crossover youth services that are going on right now. So I think we're very, very much in sync and very, very much desirous of moving in the directions that Shay's talked about today. I know we don't have time to go into a lot of detail now, but we could certainly make sure those are added to the resource page for the committee.
Thank you, Madam Secretary. And that kind of is a nice segue into a to-do list I was going to provide for you. Is I know nothing about this program in Sedgwick County, so I think we'd like to hear about that. I think, how does this tie into, how is this different than our Families First, and what are those differences and how can that all tie in together? And I can get these questions to you, you don't have to necessarily jot them all down. What is Kansas doing for trackable data with these children in our foster care system? One that you've heard from your days going back to SRS, and that is the file must follow that child timely. And so kind of at some point an update on where we at on the foster care children with that. So are there any further questions or comments for anyone on here? And Secretary, if you want to respond to me now, you're fine, but like I said, we can get those questions to you and get some follow-up information.
That sounds fine. We provided most of that to the Child Welfare Oversight Committee this summer. So. All right,
we'll appreciate that. So thank you, Shay, for joining us here today and providing this information. And if your organization does come up with some ideas on the virtual, we definitely would like to hear back from you on that. So we appreciate your time today.
Thank you, and it was a pleasure being in front of you all.
All right. Committee, we're not doing too bad. We're about 15 minutes behind. So what we're going to do right now is we will go ahead and break for lunch. Everyone that is scheduled, and I will ask David if you would try to get hold of Beth Patton for us and move her down to about 1:20, if that would be fine. And let's try to get back here. We'll get back on schedule. So we are recessed until 1:20. Thank you. How you doing?
this. I guess we have to leave it in there, but we're not, I don't know.
You're not sharing the document. All I'm seeing the open file.
Oh. You're right. This part here is smart from server.
Next through DNS now.
It did change that. Oh, well.
That's one thing we've changed since this was last updated. Another thing we've changed.
Your schedule start at 1:20? Okay, but it's probably not gonna start. Yeah, okay, I was like, it's 1:18, right? Where is everyone?
Yeah, I think we'll be looking to start at 1:25.
Okay, that's what I was like, hey,
You were correct.
well, Amy just asked for me to run downstairs real quick, and I was like, sure, let me turn this mic on, and then I'll be back at time, and I was like, oh, I don't have time. I was like, there's nobody here but me. Hey, how are you?
How are you?
I'm doing good, thank you.
I hear we got new phones.
Oh, yeah, in the offices.
And no one knows how to use them.
No.
There's no instructions.
There is no instructions, but they're very similar to what we had. So it kind of, you can kind of figure it out as you go, but it's a little bit fancier actually. It's just it's the same model upgraded.
Upgraded?
Yeah, so that, I mean, it's really the same, just a few different.
I'm surprised they don't put
Mike's is maybe turn the lights on. Okay, are you there? She's muted.
Yes. Yes, I'm here.
Beth, I was telling the committee, I didn't have my mic on earlier, so that was my bad. Is that we'd heard from you at the Can Care Oversight Committee, and I thought it was worthy of the Mental Health Committee to hear your story. So we do appreciate you being with us here today.
Thank you.
So go ahead.
I'm not sure if everybody, do I need to go over the other? I have a PowerPoint slide that gives a better timeline kind of explanation of everything. I could kind of briefly go over what I went over with the testimony that I gave last time real quick, and then I'll kind of do the PowerPoint slide. It's just one slide. Because it gives a better overview. But basically, I was an advocate of a parent that has a child in Southeast Kansas. And she had some mental health concerns since December, but they quickly exacerbated. And there were some issues that occurred quite frequently. And what ended up happening was that several hospitalizations, and now the child is actually waiting for a PRTF bed. So the issues that occurred that were alarming were basically services. The two areas were services that were not provided upon requests, and also coordination of care. So in this testimony, the specific examples were repeated requests for respite hours. The parent asked for those. It was either we don't have the personnel to do it, we don't do it in the home, or those types of answers were given to the parent. The respite, that was for attendant care, I'm sorry. The respite was I think the child was at a screening point and they couldn't screen the child. She didn't meet criteria. The they went to look for the respite for the night, and the respite was closed because of fire code violations. But there were no other options. And so the parent wanted to contract, and the mental health center doesn't contract with anyone. So the parent was told to maybe send her with family. That's not a respite option because there were some other issues that couldn't happen. There were, the big issue was that the second time the child was screened, they were sent to a non-Medicaid hospital 3 hours away. So out of state. And the parent went home, and then the parent got a call that the hospital was going to charge her $17,000 for the stay because they didn't cover it. So the parent reached out to the mental health center, and they didn't know what to do. They said, call the screening people. She thought they were the screening people. Well, the on-call people and the contractors is who had sent the child. So the parent got in the car and drove 3 hours away, not knowing that she couldn't pick up the child. So the mental health center didn't, until the parent didn't come back with the child, 5 hours later, oh, okay, now we'll help you find it, where to put the child. I mean, it was, and the parent was on the phone the entire time asking for assistance to get her child out of the hospital they sent her to. It just doesn't make sense. I mean, it makes no sense at all. It's not acceptable, actually. So now the child is in another hospital, waiting for PRTF. The whole problem basically is still a problem because when the child comes back, the services are still not here. And I know that they've been trying to do proactive work on getting a treatment plan for when she gets back. She's not even in the PRTF yet, and I know that the HMO, they're still waiting. They don't want to do the treatment plan until we can make sure that the services are going to be able to be provided. So that's kind of in a nutshell what happened with just that the parent wanted those concerns. And I don't think it was necessarily, the basic thing was that if that happens and she had someone that could kind of advocate for her, most people around here do not. I'm just telling you that she just happened to have someone to advocate for her. So on a bad day, someone that doesn't know anything, they're not going to be able to, I don't know what someone could do if their child was stuck in Springfield, Missouri, 3 hours away, and they didn't know how to go get them. I mean, I'm not sure what they would do. Call police. I mean, I'm not sure. So I don't know what a parent could do in that situation. So it's a concern. It's a big concern. And so I think just bringing it to light and saying, hey, something needs to change, is the number one reason why we wanted to bring that testimony last week. So to make it kind of bigger, and I don't know if I'm going to do this right because I haven't done this before, I'm going to share a screen, maybe. Oh, I did do it right. So last week, the parent actually, so the child is now at TLC, and I cannot say enough about TLC. Dr. Jane Adams assisted, love her to death. She's a colleague of mine, love her to death. She helped get with TLC. Kelly English has been the best coordinator, clinical director there, great advocate. She's waiting on a PRTF bed. She's at the sanctuary. DCF has paid for her to stay there because she did not want her. The child ended up going into police protective custody because she couldn't come back here. Then she went to juvenile detention center because she couldn't come back here. And so DCF ended up helping her and are still helping her be safe until she can get in. So what happened was last week, they wanted a diagnosis to start her treatment plan. And it seems like there was never a diagnosis that was updated. So the parent started looking at the records, and if I can get my mouse to work. So here are the original concerns. Attendant care was promised. And if you look down at the bottom where the purples are, these are the actual events. And at the top are the original complaints. And in the middle here in a minute where it pops up in the red, the parent went through the entire mental health records that she got from the mental health center. And all of these things are documented to have occurred. So there are some big red flags because it is in the records. So 2 days before the acute, respite was not available. She had her first acute stay, and that's where she was sent to the Missouri hospital. At that point, she was having homicidal ideations. So this is where we go back to the beginning in May when she was first started exacerbating her symptoms. In the records, she had had 5 times in the notes, progress notes, 5 times noted that she had had suicidal ideations and safety plans, and her diagnosis was never updated, ever. None of the psych units that she'd been to, had they ever updated her diagnosis. She had no diagnosis that, I think it's anxiety, trauma related, that's it. And actually, the parent couldn't even find any of her records in there from any other agencies. The parent did send her to Prairie View for an expert opinion due to some extenuating circumstances. Those records were never requested, although the parent requested it twice and it was in the records. So she couldn't even get the right stuff to the new place. July, she requested an SCD waiver screen, attendant care. The meeting was held. And during the first hospitalization, this parent in the progress notes asked every day in the progress notes, the case manager said, parent asked, parent asked, parent asked for attendant care, and it was never given. And it was authorized. They began the SCD waiver clear back in August. And they added daily attendant care on her plan, but they never gave it to her. So all these things, I guess, is concerning because before she even got to the second hospitalization, these things were on the plan. In the notes, they were on the notes in the plan, but they were never provided. So if we could have provided them, she wouldn't be where she's at. Probably, maybe not.
Hey, Beth, you need to wrap up, honey.
Yes. Okay, so basically where we're at now is that she is now where she's at. She's been exposed to COVID positive peers 3 times in the 3 facilities since she left this community. And she is now with 3 people in a different building because she cannot go to school or anything because she has positive symptoms. So I don't know what the parents can do with that, but it is what it is. So we're still waiting on what to do when she comes home. We're looking for some help. We need some help here in Southeast Kansas.
One of the things, Beth, is if the parent would be willing to sign a release form, which I believe DCF has that form. And if you have trouble getting it, we could have staff check on that. So, and it would be a release form in order for us to have the CMHC and some other people look into this case and let's figure out what went on. If the parent's willing to do that. That way we're not violating confidentiality. So are you willing to work on that?
Mm-hmm.
Okay. Are there questions for
I think, yeah, I think the problem probably is that it can't be on YouTube.
No. This would be done.
I mean,
no, you would no, it would be a form that's released so that the organizations involved on your testimony would be able to communicate with each other and share information. This wouldn't be this committee, no.
right. And they have been in communication because they know, yeah, they do know who it is. I mean.
Well, but then you can release it to be shared to a member of this committee, and we can help you resolve it, but it would not be done in the committee process. So it would not be a public discussion. No.
Right. Okay.
Okay.
Mm-hmm.
All right. Are there any questions for Beth? Representative Ballard.
Hey, I'm struggling. I can't say what departments or what organization is involved in this with you. It's DCF. All of this is DCF.
So this parent has a private custody case through a judge in Shawnee County. So DCF was not involved until the child was not able to come home from the hospitalization, the second one, because the child was then a danger to the people and the two children left in the home. So DCF was not even privy to it until the parent said, I can't have the child back until we get some help. And then that's when DCF goes, oh, what happened? And so then that's when they were going to have to put her in custody. And they said, we don't want to do that. She's already been in 3, all these different places. And so that's why they wanted to go ahead and help her stay safe in respite until she could get into the PRTF.
Okay, now that explains it to me, because I wasn't sure how DCF got in it, because I had heard you say it was a private case, but then I wondered how they got into it. So the community counseling centers are involved in this as well?
We attempted to get some respite here, or to contract somehow to get respite here, but they, in fact, through the same place she's at now, but they say the mental health center here, we don't contract. We have our own providers. We don't contract with them. So she couldn't use them. I mean, it just was like, we just don't do it. So she didn't have an option. And then it got to the point where she had to be hospitalized. So.
All right. I think you clarified that part for me, because I was writing and I realized I wasn't sure exactly what it is. And again, how old is this young woman?
13.
Thank you very much.
Thank you.
Senator McGinn.
Thank you, Madam Chair. We had a testimony from a constituent of mine and similar breakdown in the system. And I'd like to get my constituents' permission, and this did not end well at all, but to at least submit that letter to the committee, because if there is any kind of a common theme or thread in this. I think it's something we need to look at.
All right, further questions, comments? All right, thank you very much, Beth, for being here today.
Thank you.
All right, next, we've got an agency response from Andrew Brown with DCF, or I mean, KDADS, excuse me. I tried to change agencies on you.
That's okay. We're hoping maybe someday we'll be one agency, right? So.
Secretary may be unhappy I'm moving her employees around, so.
So my name is Andy Brown. I'm the Commissioner for Behavioral Health Services at KDADS, and Madam Chair and members of the committee. I do want to just say that, you know, I do feel like I have a responsibility to the citizens of Kansas to oversee and facilitate the behavioral health care of children with serious emotional disorders, and to be a good steward of the funds that are invested by the state and the federal governments for that purpose. It's not a responsibility that I or the staff at KDADS take lightly. All of us that are here today, I think, share one common goal, and that is that we're here to try to improve our current system of care through modernization and reform for the benefit of some of the most vulnerable Kansans. And Ms. Patton's testimony today and last week, I think, pleads for someone to be accountable for the system of care and the CMHCs. And I'm really here to be that person because I agree with her that accountability is important. With regards to her desire to maintain the confidentiality of this case, I'm not going to disclose any of the details of the family or the youth, nor the specific CMHC in my response today, although I am aware of the case. It is very familiar to me, and I recognize it right away from reading her testimony last week. Cases like this, sadly, are not unique. The BHS staff and I frequently, multiple times a week, must work on cases that our systems of care is not adequately prepared to respond to due to the high acuity and behaviors of the youth and special needs that they have. As a result, it's not unusual for these cases to land on my desk when the family, the providers, the MCOs, and the courts feel that they have run out of options. And last year, I also spoke with a father who asked me to create a learning system so that cases like his daughter and so many other Kansas children could help inform the continuous improvement of the systems of care for other youth. Ms. Patton is simply asking us for the same thing, to learn from this case and to make improvements and to meet our obligations as a state agency. And to that effort, I want to provide some insight into some of the errors that Ms. Patton referenced in her timeline of the testimony and some of the corrections that have already been made as a result. So one of the things that she brought up was having the child sent to the hospital in Missouri without insurance coverage. So when this child was screened, it was done after hours by HealthSource, a CMHC subcontractor that handled state screening around the state, and transport was arranged. Upon admission, it was discovered that Kansas Medicaid was not accepted at the hospital. And when the parent was notified by the hospital and advised the CMHC then began looking for alternate hospital placements. When the parent was advised that the child was considered too high risk to be discharged and must be direct transferred to another inpatient facility, that's when the CMHC coordinated transfer and provided transportation to the parent. And that's why there was some confusion about her going and picking her up. So to prevent this from occurring in the future, HealthSource protocols were modified to ensure verification of payer source before referral is made to a hospital. KDADS considers this system problem resolved and corrected. I do not believe that we will see this be a problem in future cases. Lack of access to attendant care is another thing that was brought up in the testimony. This is an issue that is not unique to this case or this CMHC. Most parents of SED youth will report difficulty in accessing and maintaining attendant care services due to the workforce shortages and turnover. However, it was certainly the case that in the early months of public health emergency that attendant care staff at this CMHC declined face-to-face assignments due to perceived risk. Attendant care service availability is back to full operation at this CMHC now. However, children's attendant care service is still limited to home and community settings and is not available overnight due to facility limitations requiring an RCF license for patients under the age of 18. Current diversion and crisis center that provides overnight attendant care support is restricted to the adult population in this service area. KDAD's worked to include attendant care codes in the telemed expansion of Medicaid during the public health emergency in response to parent input, which indicated that they would prefer to maintain those services for their child even if they were not face-to-face. KDAD still continues to consider this to be an ongoing system issue related to workforce shortages across the state. Another concern that was brought up was the delayed SED waiver screens. And this issue is perhaps more of a miscommunication issue than a systems issue. But the SED waiver applications require the child to be present for the screen and the parent to sign the application before it can be processed by KDADs. In this case, the youth had to be discharged prior to the screen. When the child was admitted to the second hospitalization, the parent had not yet signed the application. One of the first questions I asked when the case was brought to me was if the SED waiver was in place yet, and if not, what was the status of the application so that we could fast track its approval at KDADs. This process normally takes about 2 to 3 days to verify eligibility and approve services. BHS staff at KDADs met with the MCOs and DCF to review the status of all children on the PRTF waitlist prior to their admission to a PRTF. This review is conducted weekly, and the MCOs have come to expect KDADs to require SED screens for those youth without the waiver. KDADs considers this issue resolved from a systems perspective, but does wish to point out that there is no wait list for SED waivers, and that the SED waiver itself remains underutilized in Kansas. Another issue that was brought up in the testimony was the lack of access to respite care. So there are several specific issues to this case which led to this situation. The first is that at the time of these requests, the respite care facility operated by the CMHC had indeed been required to close by the state fire marshal's office while they were upgrading their fire alarm system. The second is that respite care is an SED waiver service, and at the time the waiver was not approved. The third is that the respite care service is limited to short-term 24 to 72-hour stays, medically necessitated based on planned admissions and prior authorizations from the MCO and the child's care plan, which is based on the number of approved units. In this case, the parent's request for an unplanned 3 weeks of continuous respite care while waiting on a PRTF admission did not meet the service definition in the KMAP provider manual, and so an alternate payment source was identified through collaboration with DCF. The broader system issue here is that when children with SED become threats to other siblings in their home, or even other children in treatment settings, our mental health system is only designed to treat the medical necessity at the level of need the child presents in the least restrictive environment possible. This means that the treatment goal is always to return the child to the home. KDADS has worked over the last year to license new specialty PRTFs in the state that can treat these higher acuity children safely, and we feel that this will help address some of the problem. However, KDOC, DCF, and KDADS have been unsuccessful in establishing a juvenile crisis intervention center, which would help meet this gap in emergency services. The agencies that work with crossover youth are now developing a recommendation to try a different strategy to use in place of a JCIC based on the model used in San Diego that you heard referred to this morning by our expert. That's the cool bed model. And I did not include a lot of information in my written testimony about it, but I agree with the expert that it is a very good program. KDADS considers the handling of respite care requests by the CMHC to be appropriate under the circumstances, but considers the larger system issue to be unresolved currently. And then another, or maybe the last concern in the testimony that I wanted to try to address was the poor crisis intervention planning. So KDADS recognizes that this does not reflect effective planning, and that an effective plan should have been developed with the child and the parent so that they were both aware of the plan, agreed to follow it, and did not need to request it from the CMHC. This planning also should have taken place at the hospital as part of the discharge process. I think if this had been done appropriately, the parent would have been willing to pick the child up from the hospital upon discharge, and DCF probably would not have had to be involved. KDADS will work to develop technical assistance opportunities for workforce development around crisis intervention planning and offer that as a corrective effort. This will also be a key aspect of the Zero Suicide Grant Initiative, which is being launched this fall with the CMHCs by KDHE. I'd like to thank Ms. Patton for her prior testimony and for highlighting some of the system issues by using this case as an example. I've met with parents from all around our state and talked through tough situations that they find themselves in regards to everything from not being able to find attendant care to the death of their children by suicide. We all want more out of our systems of care and for our children to live the best lives that they can. And I'll keep working with you to improve the system the best that we can, and I'll be accountable for the failures and mistakes along the way. But as Kansans, we have a lot of work to do yet, and KDADS is going to need your help to make this plan work. Thank you for the opportunity to present this information today, and I'd be happy to stand for any questions.
Any questions? Representative Glenn.
Thank you, Madam Chair. I'm just wondering if there's not an ability for us to work with some of these private hospitals for acute.
Say again, please.
Is there any ability for us to work with some of the private PRTF hospitals for these acute care cases?
We already are working with the PRTFs. Currently, we have 2 PRTFs that we are working to license specialty units on that I mentioned earlier.
Are these the private ones? Like I know we have like Marillac and Johnson County. I'm not sure what other ones are available throughout the state.
So Marillac would be a private psych hospital for youth, not a PRTF.
Okay, well, are we able to work with these private hospitals?
Yes, so KDADS has recently been working on a state institute alternative plan so that we can work with private psych hospitals on admitting patients that have been screened. Currently, we are under contract with KBC for that purpose as a state alternative program for youth. But we're looking at this SIA policy as a way to do that for both youth and adults. And that would be part of our regional hospital model that we're trying to roll out to help lift the moratorium at the state hospital at Osawatomie.
Representative Carpenter.
Hey, Madam Chair. Commissioner Brown, how many acute beds do we have? You mentioned that last week in Can Care Oversight at KBC. How many do we have now?
Yeah, so the count on the census changes almost daily, and I did not pull that prior to this testimony. But we have almost 300 children's psychiatric hospital beds that are licensed in Kansas. And the census usually runs around about 280 or so children.
That meant acute care.
That's what I'm talking about is acute care.
The 300 acute care beds.
Licensed, yes.
Okay.
You asking for juveniles or adults?
Right.
Yeah, those are juvenile beds.
Those are juvenile beds.
Yeah.
I know there's quite a few in Wichita.
Yes. Yeah. The majority are either in Wichita or the Kansas City area.
Thank you.
Representative Ballard.
Thank you, Madam Chair. I want to follow up on that. When we talk about working with private hospitals or clinics, do we have somewhat of a concern in that many of them do not accept Medicaid?
So for the children's hospitals, most of them do accept Medicaid here in Kansas.
So most of them do?
For children, yes.
Children, okay, but not for adults?
Correct.
Okay.
Most children are going to qualify for the SED waiver, which makes them Medicaid eligible. And then we contract specifically with KBC hospital system in order to cover children that are uninsured.
I should have been more specific because I was a little surprised by that. But that's mostly in Missouri, am I correct? Not necessarily our hospitals on the Kansas side? that would accept Medicaid?
Most of our children's hospitals in Kansas accept Medicaid.
Any further questions? Is there anyone on Zoom that had a question? All right, seeing none, thank you, Andrew, appreciate it.
Absolutely. Thank you for letting me be here today.
All right, now we're going to do some briefings on the remote mental health services. And first up, we have Kyle Kessler with the Association of Community Mental Health Centers.
Good afternoon, Madam Chair, members of the committee. Can you hear me all right?
Yep, welcome back to committee.
Great. Thanks, Madam Chair. And I'll really abbreviate my comments. You guys hear enough from me. And I think that we do kind of have a dream team lineup in terms of telehealth services and access discussion goes. One of the things I'll say to help connect this morning's conversation relating to the issue relating to the escalation of suicides as cause of death. One of the things that we're seeing in the CMHC system, and I think the behavioral health system around the state, is the number of cases that go from no connection or involvement with CMHCs or treatment providers at all, going right to crisis level. And so that's one of the things that telehealth can really do in bridging the gap, because if people don't get care or treatment quickly enough, then going right to from crisis to suicidal or harm to self is very, very, very fast. So I think that that's something that is worth keeping in mind. And it's not just that people aren't available, like was mentioned this morning a little bit in terms of access, but with the folks that we have lined up, John Evans, Kathy Mosier, and Walt Hill, the three of them have appeared both nationally with the National Council for Behavioral Health, as well as our state association conference in just the last month. So I think that they have a lot to add to the overall telehealth conversation. And just to give them very brief introductions, Mr. Evans is the CEO and co-founder of Innovatel Telepsychiatry, which is a national company based out of Northwest Pennsylvania that provides telepsych services in 17 states. And he has over 30 years of experience in behavioral health. And prior to starting Innovatel, he had the opportunity of starting the first freestanding community mental health center in Northwest Pennsylvania. And with his background and experience in various levels of clinical setting, he has now seen how challenging the recruitment and retention of psychiatric providers is, and founded Innovatel with the mission of timely access to quality care. Kathy Mosier, several of you know, after having been on the mental health bus tour or having seen her in front of the committee, she's a licensed clinical psychotherapist and has served as the executive director at Central Kansas Mental Health Center for the last 7 years. They have responsibility for 5 counties in Central Kansas, and she has over 20 years of experience at 3 community mental health centers and 2 in her former role with the state of Kansas as the assistant mental health director. Lastly, Walt Hill, we kind of consider Walt to be our dean of telehealth, as he's been doing telehealth for over 2 decades now. And he's a licensed clinical psychotherapist and is the executive director of High Plains Mental Health Center, and they cover 20 counties in Northwest Kansas. He could probably tell you how many times the state of Rhode Island would actually fit in his catchment area. And he has served our system in a variety of professional roles for the last 40 years. And in his last 15, he's been the CEO of High Plains. So that, as you have questions or need additional information, we kind of put this together last week after visiting with David Fye. And so if there's information that we need to follow up on with additional testimony, then I'm happy to compile that and submit it to the committee. So thank you, Madam Chair.
Questions, comments for Kyle? Seeing none, thank you, Kyle, appreciate it.
Thank you.
So first, is it, okay, do we have just one?
John Evans, and I believe that there's just one slide deck that Legislative Research has. So it will be John Evans, then Kathy Mosier, then Walt.
Okay, that was my question, make sure I only had one piece of testimony left. So Dr. John Evans, welcome to committee.
Thank you, Madam Chairman, and thanks to committee, and especially to Kyle and Kathy Mosier and Walt. We work, as you can see, in many states as outlined here, and I really want to compliment the Provider Association in Kansas and the leaders you have there. you really have progressed beyond many areas where we provide telepsychiatry partnership. But there's always more to do, as you all know. And I think I listened intently to the testimony right before us, and I can tell you that that's sadly not an uncommon occurrence in every state we work in. And to that, our mission, quite frankly, in my experience, both clinically and as a healthcare administrator, is timely access to care fundamentally makes the difference in outcome of care, both measured outcomes, patient satisfaction, and I think importantly to all of you who have fiduciary responsibilities, it is demonstrated over time to reduce the overall cost of care at all levels. So that's our focus everywhere we partner with provider agencies across the country. And I'm really pleased to say that we're soon going to be in 2 additional states. Some close to you. We're going to be active in Colorado and Texas. So we're really pleased about that and pleased about our partnerships. Real quickly, a little bit about my personal history. I'm a clinical psychologist by training, and my first 10 years was in the emergency room seeing patients and doing a thorough, thoughtful evaluation. And really, our job was to get them where they needed to be, and we did that quite well. I had the unique opportunity of being the founding CEO, as Kyle mentioned, of the first freestanding community mental health center in our region. Governor Tom Ridge proposed a program to systematically and fundamentally downsize the state hospital system in Pennsylvania. So we were funded to meet with individual patients and bring them out of the hospital to our clinic. And so the first 200 patients we saw had an average length of stay at the state hospital of 8 to 10 years. So they were very impacted by their illness. And we were a little worried when we started the project as to whether or not it would be successful. And looking back, it was successful beyond our expectations because of 3 fundamental issues. One is there was an array of housing that was thoughtfully developed for them to go to. We were adequately funded for psychiatric time to be able to see individuals frequently and in a timely manner, which was fundamental to the program. And the governor and his team made sure that the new line of medications to deal with psychosis were properly funded. So we were actually a test site for a new medication called Clozaril, which is now the standard of care. So the evidence that it showed is that with proper thought and evaluation and funding, that we can be successful. And the state of Pennsylvania over time saved millions of dollars on the per diem cost of state hospital beds over time. So we're really pleased about that. That clinic grew over time as hospital clinics started closing down. When our team left there in 2014, we had about 7,000 active patients, a very active comprehensive crisis program. And to maybe comment on the discussion earlier about a crisis residential for juveniles, we were funded to open up an adult crisis residential unit. We were able to build that, staff it for easily $1,000 a day less than an acute care bed. We were never able to, unfortunately, get funding for a juvenile facility, but thought that that would have easily equal, if not better, results. So with that, I'd like to go to the next slide, other than to say we are clinically owned and operated, and that the data continues to be pretty significant in regards to the supply-demand equation in this country, which I think is only going to get more challenging because of the increasing demands. This slide, in fact, shows the most recent data from McKinsey and Company, which is the top analytic company that all healthcare investors go to say, where are the high needs in healthcare? What I think is really exciting for me as a clinician and as an administrator is that finally we are having a national conversation about the need for mental health care to be fully integrated into the healthcare system. As you probably all know, that wasn't the case some years ago, that mental health care was really not talked about. It was a secret. People were ashamed about it. And because of the work of individuals like yourselves, Kyle, Kathy, and Walt, and at a national level as well, this is now a national conversation, which I'm really pleased about. I think what we need to do collectively now is work closely together to make sure that it's not uncommon for regulatory structure to fall a little bit behind the advances in healthcare and technology. And so I really want to applaud you for even having a committee about modernization of mental health. quite frankly, this is the first committee I've been asked to testify with this topic in mind. So my compliments to you for being thoughtful in that. If you look at this McKinsey data, it indicates that going forward, primarily as a result of COVID, that our demand issues are going from 1 in 5 of every individual in this country in a given year needing mental health care to 1 in 3. That's millions more individuals coming to the front door of Kathy Mosier's and Walt's organization. And how are we going to cope with that in a timely way? That's the essence of our partnership with everybody. So as you can see, if you segment it out, it's probably not a shock that frontline healthcare workers are having the biggest impact because of the immense stress they're going through. We actually just started a contract with a fairly large hospital system in Missouri that is concerned enough about their staff. They want us just to be available to their frontline staff to be able to get on screen, have a therapy session about the immense stress they're going through. And as you can see, they're estimating that a minimum of 35 million more individuals this year will have a need for mental health care. And I don't know about you, but at my home, I can certainly say the stress has increased. My wife requires me to leave the house at 5 in the morning, and I'm not allowed back in until 5 in the evening. Otherwise, she might do something unpleasant to me. So we've had enough time together in the house, in other words. And I think all families are dealing with something at least that minimal, if not more. If you go to the next slide. And by the way, I would welcome questions as I go through this, but certainly can wait till the end. So in result of COVID, one of the things we had to do was a very quick pivot. Pre-COVID, all of our relationships with clinics were 100% in brick and mortar clinics, partnering in a very detailed way to ensure that we had psychiatrists, psychiatric nurse practitioners, and psychiatric social workers scheduled in every day at a prescribed time to be in a telepsychiatry office, to meet with patients and have the same exact experience they would if they were sitting in the room. They're just meeting with their clinician on a large 45-inch flat screen TV on the wall, having the same conversation. We document right on the clinic's chart and make sure that everything is at the standard of care that it should be. Well, when COVID hit, as I'm sure you know, clinics rapidly started to quarantine both their patients and their staffs and started closing down. But we could not let care go undelivered. So we searched through and found a new platform that we purchased at no expense to our partners to allow us to connect with our shared active patients in their home with very little technology requirements. So for example, a patient would receive an email from the clinic saying, your appointment is with Dr. Smith tomorrow. She's looking forward to seeing you. They'd get a call 15 minutes before, and all I have to do is click on a link on that email, and they are magically either on their laptop, cell phone, or tablet connected with their clinician as they would be in the clinic. If an individual does not have one of those devices, the technology immediately transfers that to a phone call so that we can have the same exact experience and care. And so as a result, we had very little loss of care. And in fact, the no-show rate for patients has gone from a typical 25 to 30% for an ongoing visit to less than 5%. So I think our patients are telling us how they would like care delivered, and we're happy to do that in that way. Next slide, please. So just to summarize that, our care to patients directly to them in their home is now over 95% every day versus 0 pre-COVID. And we plan to, in concert with our clinics, offer that as an option for our patients. I thought this next slide would be helpful, and I'll go through this real quickly because you're probably all aware of this, that there's been an immense, rapid, positive change in regulatory waivers as it relates to the delivery of telemedicine. And I want to give CMS credit. They have led the way. Many states have followed suit. And what this has done is waived a number of the regulations that were appropriate for the past way of delivering care in person, but not especially helpful in regards to telemedicine. So as you can see, CMS has waived regulations in regards to the location of care where that's delivered, regarding the type of visit that we can provide, specific policies that relate to rural mental health, and as support for broadband expansion and the overall Medicare approach to telemedicine and telepsychiatry. We've also had a temporary waiver of the Ryan-Hyde Act, which would not allow us to prescribe controlled substances over an internet connection. It requires a direct face-to-face visit. This is most especially helpful, and specifically where we see children and the need for stimulant medication to address the diagnosis of ADHD. We are very conservative. We do not do pain management, and we do not do Suboxone buprenorphine care at this time. We do see that there's an immense opportunity if the DEA would make these waivers permanent, that we could really open up the timely access to care for addictions. But at this point, we cannot do that because of the regulation. Any questions on that slide? And I have one more slide, and then I'll turn it over to Kathy. So the next slide really addresses some of the things we've talked to other state regulators about. We've not had the opportunity to meet with an actual legislative body such as this, so I'm really excited about it, needless to say. So of course, we're very pro payment parity for telepsychiatry and telemedicine. We do have a formal relationship with Patrick Kennedy, who, as you know, is the author of the National Parity Act, and feel that our clinics deserve to have a sustainable rate for the care they deliver. It is very challenging in psychiatry these days because of the small number of psychiatrists available and the immense demand. I can tell you for a couple of reasons, we're losing psychiatric capacity nationwide. The most fundamental reasons are the aging out of licensed psychiatrists. Over 50% are approaching 60 and older, and they're starting to retire out. The pipeline from residency schools is not going to be able to fulfill that. And even more disturbing at this point, the last data I read is 45% of all psychiatrists nationally in private practice have gone to cash only payments because the demand is so high, and from people with resources are paying anywhere from $500 to $700 an hour for a psychiatric appointment. In large metropolitan areas, those practices are full and not accepting new patients. Our mission is to partner with community health centers and treat those individuals who have the highest needs and lesser resources. So it's a concern that's going to continue to affect that. With that said, our pipeline of recruitment for psychiatrists who want to join us is really quite full. Physicians want to work now remotely from home for a whole host of reasons. And we can get a better price point, I believe, on our psychiatry than in the private market. Of course, we're certainly advocating for flexibility on that location where patients receive their care. With that, we are accredited through the national accrediting body of the American Telemedicine Association and do not compromise on the standard of care at all, regardless of where care is delivered. We would like some expedited opportunities for licensure. States have different, I think, cadence for how a physician gets a license. I can share with you another state has found a path that's quite acceptable to us for an extra fee. They will expedite the license because of the timeliness of that. We're always happy to support that extra fee for a qualified physician just to move that license along. And if you aren't doing that, would encourage you to maybe consider that not only as a way to get highly qualified clinicians into the treatment care, but also to enhance revenue, which I don't know of a state that's not looking for that opportunity as well. And then, of course, we're advocating for full practice rights for psychiatric mental health nurse practitioners. These are master's prepared psychiatric nurses that have full prescriptive rights in other states. And they can work for about half the price of a psychiatrist, but can do literally everything a psychiatrist can do. So those are the issues I'm advocating for. Happy to answer either questions now or turn it over to our great partner, our first partner in Kansas, I might add, Kathy Mosier.
I think what we'll do at this time here, if you don't mind, is we'll see if there's any questions on the slides that you presented to us before we go to Kathy.
Happy to do that.
All right, committee, are there questions? Senator McGinn?
It's not really a question, it might be a request for information. On the licensed psychiatrist, I don't know if anybody has that number. I've seen it in committee before across the state. And one of the things we also found out is, say the number is 100, of that 100, maybe 25 are already retired. They just keep their license. So it would be good to see that solid number of the ones that are actually practicing. Data.
That's what you did.
Yeah. Thank you.
Many other questions? Anyone on Zoom that has a question? Dr. Evans?
Well, listen, I really appreciate the time, and again, compliment you on even having this hearing for looking at how to improve and modernize the mental health system. You're really ahead of the curve on this.
All right, and we appreciate you being here today. And I'm sure that as we go through this information, we may have questions later on, but we know how to get hold of you. So thank you very much for appearing with us today.
My pleasure.
Welcome to committee, Kathy.
You're on mute, Kathy.
That mute button gets you every time.
Every time. Well, I appreciate Madam Chair and members of the committee for having me today. Thank you. And John, thank you for that lovely information that in Kansas, we don't collect even half that rate for an hour of psychiatry. So if I'm not, I know you're not either. So thank you for what you do to partner with us. My name's Kathy Mosier. I'm the Executive Director of Central Kansas Mental Health Center. We're based out of Salina, and we have an office in each county that we provide services to, and that's 5 counties. I have been asked to answer a few questions about telehealth, so I'm just going to dig right in. How did we initially see our operations change in the first weeks of the pandemic, going from face-to-face to virtual? Well, in the first weeks of the pandemic, we converted our operations, did that pivot change that John's talking about. 5% telehealth is where we were at, to 85% telehealth to prevent gaps in service for our patients. You know, if you would have been one of our schedulers calling patients, as this is before the emergency was even declared, before a stay-at-home order, the word was just getting out and patients just started being too nervous and frightened to come in. And as soon as that started happening, we said, we got to do the right thing here. They need these services. So our schedulers would tell you that they would call and say, hey, we noticed you're on the schedule. Would you prefer to have a telehealth appointment instead of coming in today? And overwhelming appreciation and gratitude from our patients saying, yes, I wasn't going to show up today because I was afraid, I didn't want to come in and I didn't even know if you would still be open. So that was one of our first experiences. And I'm going to go right into a couple examples of what we learned from telehealth. One starts with a little girl who was coming in for sessions. She had just started, had come in for about 3 sessions and was having a really hard time opening up. Suspected maybe some trauma going on in her life, but struggling to get an understanding of that. And so when COVID hit, the session was in her home. And so from the remote session, the therapist said, I want you to go to the room where you feel the most safe. And we're going to talk through our devices in there. So she went to her bedroom and showed her therapist her pretty pink bedroom. And she wrapped herself in her favorite blanket in her room. And the session began, and she picked up a doll and showed it to the therapist. And the therapist picked up a doll and showed it to the little girl. And the little girl started talking through her doll. And the doll, so the therapist responded, and the little girl corrected her, and she said, no, 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 we don't talk. Only the dolls talk. And when that happened, her doll, through her voice, talked through the doll and opened up and told her and about the trauma that she had experienced and what she was going through. And it was a huge breakthrough. We were able to understand that trauma, get things in place for her and start her on her road to recovery. Another situation happened when we had some foster children who a CASA worker said, hey, these children have been displaced. They can't stay at this foster home. They're going to end up in Wichita. They don't want to see anyone down there because they've already started with you guys. And I don't know how to help them get started. How do I help them get started in Wichita? So what we did, because of COVID being in effect, we said, well, we can take this as fast or as slow as you need us to. We're here. We can continue to meet with them through telehealth. We can work with the community mental health center down there, who is going to have a lot of auxiliary resources. Also, other community partnerships down there, whether it's financial aid or school supplies or other things, we tap into we integrate with the whole community. And so we were going to do that with Wichita as well. Well, what worked best for them was to continue to see the therapist with us, which allowed us to then switch the community-based services that go into their homes and things down to the community-based down to Wichita. But we kept that therapist in place as a baseline and a foundation for them to build on. And then we integrated our care. We had an adult where that happened, the same thing. She moved to Topeka and she had called and said, I'm not doing very well. I can't go in and see the people you referred me to, and I didn't show up. And I only trust 2 people in my life, and you're one of them, is what she said to our therapist. And the therapist said, well, I'm glad you called because the world's kind of changed. And if you need to keep seeing me for a while, I can help you with this. So we were able to continue services for her as well, which, so I think with foster care children and things, that opens up kind of a whole new layer of maybe stability that we can get better at. And then finally, connectivity in homes. When we started connecting directly to homes, that was different. So the normal origination fee that we can add on revenue for that telehealth service is called an origination fee. When we receive them, usually we're taking vitals and things. But when it was in the home, we did not have access to that origination fee, just the telehealth code itself. And thought, okay, that makes sense. We're not taking the vitals. And what we found was that when you're in the homes with especially severely emotionally disturbed adults or severely persistently mentally ill adults, we found that there's connectivity issues. Sometimes it's spotty, the internet's spotty in their neighborhood. Sometimes they don't know how to take off their mute button, which apparently I need to work on too. And so between all those issues, if they got kicked off because they were in a residential area that didn't have great access, they'd end up calling our front desk, and that we're trying to call them. And, great plans are that we'd say, okay, if we just get disconnected, here's what we're going to do. But you're still trying to work out all that connectivity. One of the greatest things that we had not thought of was when they opened up the phone conversations. So what we could do is, instead of them getting frustrated and adding stress to their life when they're already have enough stress, and that's why they're coming to us, we were able to say, you know what, let's just pick up the phone. So we just call them and say, we've tried, let's finish, let's get to what you're here for. Let's talk, let's get to what you need us to do today. And that hands down has been the most well received by our patients, is to have that at least as a backup to say, you know what, there are patients who would have actually backed off and disengaged and said, I'm not doing that again. And so we were very appreciative of that. We knew we were doing the best thing we could for our patients and community when we just immediately said, we're not going to let services stop because they're not coming in or can't come in. But we were sweating it financially and have been ever since. And we were hoping and praying our governor would support us. The CMHCs did not receive the increase in funding or the Medicaid rates that the legislature supported and passed. But finally, what happened was KDHE did, after the fact, approve some of those waivers from CMS that John talked about, and said, yes, in Kansas, we can utilize those too. So what we were taking a chance of not getting paid on any of that, now we were able to bill and actually get that reimbursement from Medicaid. So we are greatly appreciative to them for that. And then when the CARES Act relief came and we knew some was going to come our way, our staff actually jumped for joy and started to feel more supported in their pandemic efforts to continue to be that frontline healthcare worker and provide those essential mental health services and come into work and deal with exposures in spite of all of that. So that support was so important and we so appreciate that. You know, one of our nurses even set up a tent on the curb of our place so they could drive up on the curb, and if they needed a shot in the arm, these are for injectable medications to help them not deteriorate and end up, we were trying to help keep our patients out of the hospital and out of the ER. So they could deal with COVID. So set up a tent curbside, inject them in the arm. If they needed the hip injection, we had the tent they could step into and go right out so that even COVID positive patients could continue to get their services and their medications the way they needed to get them. You know, so now we were already using telemed pre-COVID. And that was through our partnership with the Novotel. Actually, we tried 3 different ways of doing telemed to make sure we were doing it with the highest quality we could. And hands down with the Novotel, we were able to find that. And I think that's because of John being a community mental health center executive and knowing and being a clinician and basing it on all those important features that are needed for the patients. But also that integration with us and and willingness to learn all the local resources so that they were still referring and integrating care with all the community resources that we have to put together for a patient. This helped, we had a psychiatrist who'd been with us for 27 years and retired, and we couldn't fill the vacancy. We sadly found out that the supply and demand had caused the market salary for them to be 100,000 over what we were paying. That was a huge hit, and we couldn't even recruit anyone then because of working in our rural areas. And so we were appreciative of a Novotel offering us that opportunity. And we can not only fill vacancies now, but we were able to bring higher quality behavioral health prescribers into Kansas. We were able to, we even have a child psychiatrist out here now, which has had wonderful outcomes for our community. And these are bullets on the good news. Another thing telehealth did, or there are certain services that phone and televideo make for higher quality case conferences so that you can have a therapist not have to come out to the home where the case conference is going or the school where the case conference might be happening or you know, another office. So that wraparound meetings to get divorced parents who may live in different cities. One may live in another state or one may be working, so only one could attend. It really overcame a lot of those things. Our MCOs were able to attend by phone. When they had to travel and they were required to come to one, it meant that we had to really put the family had to be displaced because they only had limited times where they could come all the way out here for that. And now they can hop on the phone so we can do it whenever it's convenient for the family, which has really relieved a lot of stress. And it's true to the fidelity of wraparound, the way the best practice is supposed to be implemented. So we appreciate that as well. And I know the MCOs do too. DCF could participate easier because sometimes it was a DCF from another area of Kansas and not local. Probation officers and teachers all, you know, are examples of ways that they can all come together so we're all on the same page. We all agree on the same, with the client on the same goals that were priorities. And so we're all sending the same message and support, which makes for better outcomes because we're integrated and doing it together. So also prior to COVID, we had teens who were asking if they could schedule their appointment online. We had them calling saying, can I just do this from my cell phone, like over FaceTime or something? Well, that was kind of, gosh, how could we ever accommodate that? And then when COVID hit and CMS relaxed their rules, now those kinds of things can happen, and maybe they will make it permanent, because in some ways, a lot of our teenagers, that's the preferred way that they communicate now. They're more comfortable that way. Staff absenteeism has really greatly increased since COVID because of COVID exposures that they have, and then they get asked to quarantine. And sometimes they're healthy and they can't. So this decreases revenue when we have because we're doing a fee for service model right now. And so if they can't provide their service, we don't get the revenue. We're still paying the salary of the therapist, and they're worrying about how am I ever gonna, how can I work if they're keeping me home for 14 days and what's gonna happen to me? So with telehealth, the staff that need to be at home but are healthy enough to work can now work from home. The result is better access for patients, and we salvage some revenue into the system. This has allowed some flexibility and helped build some staff morale, especially those who have compromised immune systems. And then a bonus of COVID, mental health experts around the nation who, founders of these evidence-based practices like conscious discipline and cognitive behavior therapy, things like that, they've started posting videos and best practice tools online for free during this time. We have been collecting a whole electronic library of these great resources and using those to enhance the quality of our telehealth sessions. So it's actually been a no-cost way that we can come closer to utilizing and enhancing the utilization of best practices here in Kansas and even in rural areas. So we're very appreciative of that. And then our community-based professionals who usually work in the homes and schools, at times that's not a safe place. The whole family's on quarantine, or the ventilation, they already have 10 people in a one-bedroom house. There's things like that. So our community-based professionals can send activity kits to the patients. During the stay-at-home order, they decided that this is what they were going to do, and they sent activity kits to the homes, and they started engaging them through therapeutic activities, and could continue keeping their engagement in things like healing through art and some of those practices. So how has telehealth helped work on the school mental health pilot? Well, when the schools closed down, this displaced our school-based therapists. And we didn't have the offices to put them up in, and we didn't have people coming in. They weren't going to come in for those services anyway. But with telehealth, they could work remotely and they could stay connected. And the students, through the whole time while the schools were closed. But in addition to that, we also partnered with our school districts, every one of them. And so that the students ended up being able to keep their school issued devices and keep them over the summer, so that because now the schools more than ever understand the importance of social emotional learning, and also mental health and services, and not having those gaps. And so we were able to utilize those devices over the summer to continue to keep for students who were not able to do the in-home or community-based services yet. And that's been kind of going up and down with the spikes in positivity. So this reduced no-shows and gaps, and this certainly is aiding in suicide prevention, as well as the whole school mental health initiative. So how might telehealth be sustained, or at least be an additional tool going forward? Well, one thing Kansas can do is align with CMS, like John was saying, and approve the same flexibilities as long as they're in effect. We're still learning what works and what doesn't. Parity in payment is going to be absolutely essential. there are so many payers out there that currently, when we started telehealth 4 years ago, they put all kinds of hoops and barriers on telehealth that it's not worth doing. You can't do it. And in the field of behavioral health, it is necessary. It is an adequate way of providing the services, and we can't afford to do it if we don't get the full rate. So please don't allow a lower rate for telehealth than you would if it was face-to-face, because in terms of behavioral health, face-to-face televideo is face-to-face, and we need to think of it that way. The restrictions on telehealth do cause operational barriers, and barriers should not be there at all unless it can be backed by solid research or a good reason. And so I would really ask all aspects of all of our systems to think about that and to just not fear the opening of telehealth, but instead fear not opening telehealth. In other words, if there's a reason to put some boundaries around it, that's great. We'll support that. But don't put them there when there's not a reason yet. You're just a little nervous to open it up too wide. Let us learn that and we'll figure that out. The other thing is, and I kind of touched on, is parity with in-person versus telehealth. Again, the restrictions on telehealth, they cause operational barriers, and so they should be backed by research. But the qualified clinician's professional judgment and the patient decide together what the treatment plan is and use that clinician's judgment to determine that medical necessity. So why wouldn't telehealth be the same way as treatment planning, as developing that treatment plan? It's one more modality of treatment that you're building in a treatment plan. And so it's that professional qualified clinician's judgment and the patients together to decide what is and is not appropriate in an ideal world. There are some unforeseen times when telehealth can be an option so that the patient can continue to make progress. So even in services that you wouldn't think, maybe you'd think, oh, that's not a good one to do telehealth in. Well, there may be times where that works. Take the farmer, for example. Oh, I didn't tell you the farmer example. I skipped over that one. There was a farmer, we had a farmer who was struggling with depression and suicidal ideation. And he was on the verge of needing inpatient care, and we were trying very hard to keep him diverted and stabilize him. But he really had trouble coming in and getting his sessions regularly. He was not consistent about attending his treatment sessions. And what happened was when COVID hit, he didn't show up, and we called him and we said, would you like to just do this out in the field? He said, I'm harvesting. I can't pull away. There's no way. I'm not going to be there. And so we said, well, if you'd like to do it this way, you could. And he was so appreciative. He said, heck yeah, I can sit in my tractor and do it from here. And they were able to have that session. And now it was work that was pulling him away. It was his duties on the farm that would change, and he had to keep up with those. So a planned therapy session he struggled with, but if he could do it from his front porch or from the tractor or the field and just take a break and hop on, then he was able to keep on his recovery path, which leads to quicker recovery and lowers cost for everyone. So that's an example of that in-person versus telehealth. And then on allowing the phone services, we already kind of talked about how the phone service, when connectivity fails, is a great way to keep people from abandoning treatment. We know that when people don't get the treatment they need, that is when we see the worst outcomes, and they clog the ERs, and then we're putting out fires instead of using lower cost services to prevent that from happening. But the other issue with phones is that other services, we know some of the services actually are better by the ability to use telephone. So the case conferencing, the targeted case management, and the wraparound facilitation. And if we're not going to use the telephone, or if CMS, that's kind of a CMS decision to make, then we probably need to advocate there as well. But if we're not able to do that, then we need that origination fee intact, because inpatient in their home, they call our office, they need our IT staff to help them troubleshoot. And we have to be able to afford the cost. What are the biggest challenges? I see the biggest challenges as the cost is increasing. So telehealth requires additional and better technology, equipment, periodic equipment replacement, and secure lines, connectivity, encryption software, Zoom licenses, training, keeping your staff, having staff that can stay on top of technology and use the technology, and EMR programming around that. But at the same time, the cost of therapists and psychiatrists is continuing to rise because of the workforce shortage. So if that's not addressed, it's going to be too costly to deliver services. And the reimbursement rates. So we haven't had those Medicaid rates increase in behavioral health in over 11 years, except for a couple of those little waiver services. And we really need, and legislature was supportive of that, and we appreciate that, and we know times were tough and they couldn't do that, but we not only need that more than ever, we need more than that to keep going and to keep our workforce. But our workforce, it is decreasing, and that's really important. On top of that, these are in behavioral health, they are just as much frontline healthcare workers providing essential services as well. And our mental health professionals, here's what's happening in Kansas. They're leaving the field altogether because they know they can't make it. The costs have outweighed it. Even some of the independent going into private practice, they're finding the same thing. But they're also going to all of our neighboring states. We're losing a lot of our workforce to Oklahoma and Missouri, even Kansas City, Missouri, because they adopted the CCBHC model, which is based on a cost basis model instead of a fee for service. This is what the FQHCs get to have, some similar to theirs. But we in the CMHC system have never had that. And so it may feel like we're whining sometimes, but it's really that we are on an outdated model, and we haven't gotten the things that they have gotten to do that cost basis type of, and Kyle is better at explaining that than I am, but that's a direction. But if we're losing our people to them, some of them are paying, they're paying $20,000 to $30,000 or more for an annual salary for a therapist than what we're able to pay in Kansas. That we know that we know what they're paying down on the borders for some of that and what we're paying, and it's scary. And no wonder our staff are leaving to go down there. On the other side of that is our other staff, our attendant care workers, our crisis mental health specialists who man our 72-hour respite services, our crisis house, our community-based staff. They make more going to Target and Walmart now, and Target's continuing to raise theirs, their minimum wage. Or they even make, sometimes paras in the school make more. And in all these jobs, they have half the stress, they have half the challenging people that we work with, and half the workload. There's no way we can retain staff. So we are already, the CMHCs are in a state of crisis. And I just feel it's important that if my voice is going to get heard, that message gets out there, because we want to do the right thing and we want to do it cost effectively with you. But if we don't have staff, you're going to have more of those situations like you heard prior to our testimony of, of not being able to offer attendant care as much as what they need and want. And then there is a new dangerous, I consider dangerous, a little telehealth thing that's popped up that I think you ought to be aware of. And that is that I don't know if you've heard these ads, but just recently they popped up on TV and they say things like, do you need meds for bipolar? Call. We have a psychiatrist that you can call right now. And what are you going to get if you call that? You're going to get meds. And what is best practice? Not meds. Meds and the supportive services like therapy, case management, other resources that you need in order to get the positive outcome. So I'm a little worried that these people who aren't even in Kansas, maybe not even in our country, who are putting out these numbers, that the only thing they're going to get is that telehealth. So that leaves out in person, the ability for them to do in person. So if you need in person, either they won't get it and they'll keep doing telehealth when maybe it's not appropriate, or they're going to say, bye-bye, you need to go see someone else now. And they're not integrating with the local providers. And when they're giving out meds and they're not getting in touch with local providers, that's dangerous. And we need to coordinate care. We need telehealth providers that provide that integration is very important, and that collaborate with. They also need to know the resources in the local community. You can't do a good job of treating someone if you don't know to refer them, if you don't know if your area has a food bank or Catholic charities or school supplies or financial aid or a supported work program, supported housing, those kinds of things. So it's great when telehealth complements on-site and in-person and local providers and communities, and that they work together. And then lastly is just the widespread of connectivity. And I think you're already moving in that direction with some of the CARES money to make sure that connectivity is available for folks. That's all I had.
All right, thank you, Kathy. Questions? Jane Arnberger.
Thank you, Madam Chair. I just have a quick question on with telehealth being predominantly done now. Have you ever ran into, or have you heard of anybody running into a scenario where maybe there is trauma at home and the patient doesn't want to open up because the person who has traumatized them or is part of the maybe issue is in the house and is overhearing, and they're worried that maybe mom's going to be upset, so forth?
In the case of the little girl that we talked about, there was a situation like that, but again, she felt safe to disclose that. I do think, historically, my experience has been that there are times when the abuser is in the home and does not want the information to get out. But I don't know how different that's going to be in the home as it would be in the office, and them being uncomfortable that might be coming out. Either way, I do think that if that is a risk, if they're in a home house and the child doesn't feel safe, they're not going to open up. You're going to know that that's not working, and so you're going to need to change what you're doing to find an effective way to work with the person.
Okay, thank you.
I had a comment, maybe, if it would be helpful.
Sure.
Yeah, that's a concern of ours. And what we found out is, now that we have the unique opportunity to deliver most of the care in the home, that those what are social determinants of health have become much more evident to our clinical staff. In fact, at our clinical meeting where all our psychiatrists are on from across the country, they felt it extremely helpful. Now, to your point about, divulging, risk or trauma, the clinicians have become very skilled to picking up on that and saying, would you like to maybe walk me into your room and show me your toys or things like that? And if there are concerns, pretty skilled at having a private conversation. But I think to Kathy's point, it probably wouldn't be any more evident in a traditional model, but it actually, we've been able to determine a lot of just the overall pressures that families are coping with by the opportunity to come into their home. So overall, it's been very helpful.
That's right. And I'll just add that we have learned to do things differently with telehealth. Like one of the first things we do is say, now remember confidentiality. Is there anyone else in the home that could overhear? A friend, a neighbor, your brother's friends over here hanging out, so that if, and to remember that those the patient rights are intact and the patient's responsibilities are intact. So we do cover a lot more than we used to each session about, are we in a place that's okay to talk?
Yeah, I can see how that can be an issue. And I'm kind of struggling a little bit with you saying that you could have that same type of an issue in a traditional setting, whereas I'm thinking, okay, wait a minute, the person you're counseling is in that room by themselves, not sitting.
No, what I will say is that we've had parents take, for example, a parent bring in a child and they will not let us see the child alone.
Okay, that's a different situation. When you said traditional, that's where I was getting a little bit confused with that.
Sure.
Valerie?
Thank you, Madam Chair. I want to address what you talk about Oklahoma and Kansas City paying, somewhere in the range of 20 to 30,000 more. I've heard that and I've been trying to figure out, is it because Oklahoma as a state is larger than we are?
Oh, so bringing in federal dollars.
Question I get asked, but I'm trying to think, are we so far behind philosophically about mental health that we are not investing in it more than they are, or do they have a greater problem than Kansas has and they have to do something about it?
And Kyle could probably address this better than I could. I'll just say that they are participating in federal programs that are bringing federal dollars to help them enhance their mental health services. And because of that, they are greatly expanding and able to pay competitive rates and start addressing the workforce shortage by being able to pay what the current market price is for them. Does that help?
What the issue was, Representative Ballard, was that back when the federal government offered a door, the state of Kansas chose not to walk through it. So these other states are getting a higher rate from the federal government for their mental health services than Kansas is. And one of the things that we've made requests on a regular basis is for the federal government to open those doors back up so that we can participate.
Yes.
Okay, now that raises another issue for me. And that's why I asked the question. If we miss the boat by not taking advantage of monies that were available, and we are not looking at Medicaid expansion, are we not doing the same thing again, not taking advantage of the opportunities in order to provide services, especially for Kansans that do not have it?
I would say it's not equivalent, and here's why. This program that we didn't participate in with the federal government didn't have a fiscal note. Medicaid expansion has a $60 to $80 million fiscal note pre-COVID. After COVID, it's closer to $125 to $150 million. And
10%, because 90% the federal government pays. You see, I think we can justify by not doing this, but the thing is, would it not allow us the opportunity to provide more services for mental health?
no, because currently our community mental health centers are no different than an ER in a hospital. A CMHC has to take anyone that walks through their doors, irregardless of the ability to pay. And so they do that today. The fiscal note to expand Medicaid was $60 to $80 million SGF, state general fund dollars, pre-COVID. After COVID, we are now looking at, because of the unemployed, et cetera, $125 to $150 million. The governor did a handful of allotments. The IDD population lost $22 million. They're sitting with over 1,000 people on their waiting list. The nursing homes lost their increase that we were going to give them, and mental health took a cut. So we need to fund the programs that we are currently responsible for before we go looking at any new programs that we want to take and fund. Because if we had done Medicaid expansion, that hole would be a lot deeper than what we're looking at right now. And I understand where you're coming from. And you and I are on
I
different
disagree
sides.
with that, but I'm not gonna get into the Medicaid expansion thing, because I mean, I have a stronger argument why we should, as you have why we shouldn't. But that's not the issue. The issue is, if the money was available, Oklahoma took it, Missouri took it, and everything else. The question is, why did we not take advantage of those opportunities when we knew we had similar health or mental health problems in the state?
Kyle Kessler, correct me if I'm wrong, but I believe it is because at that time, a current secretary of KDHE did not do their job. It was not a legislative decision.
It was not a legislative decision. I can confirm that part.
Confirm the other one, but I will. It was a secretary, a current secretary at that time, that did not follow through with it. Why she didn't, I don't know. I wasn't here.
And I can give a little bit more background in terms of the feds at that time required the state agencies, the State Mental Health Authority, which was KDADS, to sign off. And they also required the state Medicaid agency at KDHE to sign off. And so KDADS did very quickly. Secretary Bruffett was very supportive. We appreciated that. And then it just got stuck. And probably 3 weeks, we had actually several hundred staff hours in on our application process. And we just ended up pulling the plug a few weeks before it was due, which made it even more painful because the folks who were helping us on our application pivoted very quickly to Iowa to start helping them on a late decision to go forward on the CCBHC initiative. And then they got an award.
I just needed to just understand that part.
And Kyle, if I understand it correctly, it would have been the feds giving us a higher reimbursement rate. It wouldn't have made our match higher. Is that correct?
It wouldn't have made our match higher. I don't know that in terms of there were several pots of money that came out. One was for a grant, and then if you became a demonstration state, then you got additional grant dollars to get all of your infrastructure up and going, plus you got the cost-based reimbursement. So it increases your Medicaid share or your federal participation some, but not very much, is my understanding. Is that right, John? John Evans has a good understanding of this too.
Yeah, Kyle, I think you're right. We're in a number of states that are what are called CCBHC states, and those community mental health centers are fundamentally doing much better financially. They're able to be, and it's all federal funding. Because of that funding that's come in, they've added significantly to their psychiatric component. And one of the key components, requirements, I would say, of accepting that funding is timely access to care. So we've developed what are literally same-day access models in those states. So, which is part of our mission. If you call today, we want to see you today. And the data is really strong in regards to the positive outcomes and the savings long-term and the whole episode of care. So yeah, I would refer you to Minnesota. Kyle, Chuck Angoli of the National Council is really he has a national initiative to have 500 CCBHCs established within the next 2 years. So if Kansas were to apply and be accepted, that funding would, I think, be forthcoming. And clinics like Kathy's and Walt's would be able to submit their applications. It does fundamentally change the structure of a mental health center. We did that here in Pennsylvania before I left ours. It's a bit of a heavy lift, but the work is well worth it.
And I might add, I thank you, John. And I might add that Greg Hinnon, his mental health center, with him being on this committee, they could probably give a very good presentation over CCBHCs. They were just given a grant to go down this road, so they would be our first in Kansas.
Madam Chairman, if I might add. Thank you, Madam Chairman. This is Representative Elizabeth Bishop. As I understand it, because we didn't get in line by submitting an application for the initial pilot program that was offered 3-4 years ago, then they would expand it, expand the amount of federal money going into the entire pot the next year, and they would drop back and look at those applications that had not been approved. We never got in that line. Right. Finally, a year ago, they expanded it even further and opened it up again for other states that had not submitted those initial applications. And we did. What was it? Kyle can correct me. I think it was something like 26 applications or something like that. So we've got applications on the shelf that we can turn to the minute they expand the funding again.
Well, and that's accurate, but there's also they've as oftentimes happens with the federal government, they look at alternative approaches. And so there are states like Texas and others who also were like us and not pursuing this, which have now figured out ways to either amend their 1115 waivers or even doing state plan amendments. So there are other ways to go about this, but you just don't get the same grant dollars or upfront development dollars unless SAMHSA deems you worthy of a grant. So there are actually several different ways to skin the cat on that.
Senator McGinn. Thank you. We don't know the numbers because the Senate has never had the opportunity to debate Medicaid expansion. So
you were on the wrong committee, Senator.
And I was not on that. I was not on the health committee as well. So I have an IDD. I just want to make sure it's clear that money was not for waiting lists. It was for those people that actually care for the most vulnerable people. So my question is for the panelists. When we had our mental health tour last fall,
last September.
Yeah, it seems like a long time since things have changed around here. I believe from a lot of the providers that the Medicare does not pay for mental health, and Medicaid did pay some, although minimally. So we have situations where people who are not 65, but they end up getting put on disability, and then the state works hard to get them on Medicare so they can get off our end. And so then you have these individuals that aren't even 65 that may have mental health issues. And then I don't believe that you get much money at all under Medicare. So could someone on the panel address that? I do remember that was part of our discussion.
And I would suggest probably Walt Hill, who's the next panelist. He's one of our resident experts also on the Medicare issue.
Thank you. I believe we talked about that at the tour on the dynamic of Medicare. When people move over to Medicare, it is not nearly as robust of a payer for the kinds of services that help the people with most debilitating problems. It will pay for therapy and medication checks, but it won't pay for case management, attendant care, those variety of services. So those individuals that do go on disability, get Medicare, often have a much less robust benefit plan to pay for services.
Well, doesn't that also depend upon whether you're on Medicare, SUP, or Medicare Advantage plans?
Yeah, it gets very, very complicated. The other issue with Medicare is that it limits who can provide the service to a much smaller set of workforce than we even have now, because it doesn't pay for all that are licensed in Kansas to provide the therapy.
Right, and then you also have those that are dual eligible for Medicaid and Medicare.
Right.
And that gets confusing too.
Right, and that is, I believe I've seen those numbers. I mean, we're talking about people with very low income or anything at all. So we're missing, to me, we're missing those individuals that are, making maybe $30,000 and up and still, trying to make ends meet. But anyway, I'm not trying to have the discussion about Medicaid expansion. I was just trying to understand the dollars that we receive. And it just seems to me wrong that Medicare doesn't crack that door open a little bit more, because I think, even now, you talk about COVID, talk about the nursing homes, we can talk about a lot of stuff of people that have depression and mental health issues now because of that. But that's all I wanted to say. Thank you.
Yeah, most of them that are in the nursing homes, a high percentage are Medicaid patients. No, but the large percentages. Right, and that's different than your nursing homes. Yeah, but independent living are more than likely private pay.
Correct.
Because independent living, and then, what's the other one? But you have nursing homes, you have independent living, and then you have, that would be your nursing home. What's the one in between there? And I'm just losing the terminology. Assisted living.
And I don't disagree, but I actually know some of these people, and I know how much they make, and I know that they can't pay for mental health services.
Mm-hmm. I'm going to have to go get my notes if we're going to go down this path.
Oh, no, we're not going to dial it.
And then I may not be aware of this special maps that I gave us later. So.
Oh, honey, you'll be all right. But I think you can see we're friends.
But I want people to think we're mad at each other.
No, but the point I understand part of that, but with Oklahoma and Kansas City, the other part I do want to cover seriously is, does really Oklahoma really have more revenue coming in because of, than we do, and Missouri has more tourism and other avenues of revenue. So I'm just trying to figure out, in addition to grant money or whatever they have, do they actually have more revenue coming in from their state, whether it's oil, whether it's tourism, in addition to just that grant? Are they just financially better off? Because I don't think they're more progressive than we are in terms of healthcare and everything else. That was the reason I was asking the question.
I think they probably, if we were to actually analyze it out, I bet we'd find out they've got more providers. They don't have near the workforce shortage that we have, but then they're able to pay those individuals more per person than what Kansas can do.
That's all I was looking at, just to see. I didn't want to get into that part of it, even though we got into that part. But that's
I just need to bring my packet down.
I just want to make sure we look at it when they say that. And I keep thinking there's a stigma attached. I don't care who's doing it to a certain degree, but do they have more money that they can spend on it that we don't have? That was
right. Well, I think when you talk about the parity payment, you're opening up it's not just about what the state does, then you're also bringing in your private insurance companies, and then the battle begins. So the parity payment issue is not as simple as what it might sound like. Kathy, I'd like to go back to you on the telehealth and working with children, because some of the individuals that I have visited with that deal with these kids have a concern about telehealth for some of the younger kids, say 8, 9, 10 and below? Are you not seeing that as a problem?
Yeah, because it's a difference to me, the clinical judgment of the professional and the child and family need to work together, because in some cases it's very effective. Some people feel much more comfortable in their home, in a safe place in their home, having that instead of coming into an office, or for teenagers coming into the mental health center when you live in a rural area and people know your car and it's parked outside. On the other hand, I think maybe what you've heard is that at first, I think telehealth was pretty exciting for the kids, and and then they got zoomed out with all the school zooming, and some of that has fallen off. A little bit of the engagement, the excitement and engagement has fallen off. And then also realize that some of our services were provided in their community, in their home, at the park. Getting kids to open up, sometimes we do that over a Coke. We pick up a Coke at McDonald's and go to the park and talk to them. So those aren't the therapy services. Those are more the attendant care and the respite and the case management type services. And so I do think that there are times when that has fallen off because kids aren't as engaged in the treatment this way as they are in some of those services that we make more fun and more strengths-based and about their life. And we do it in areas that are where they live, eat, and breathe. So we go to their local park, to their home, to their yard, and we do activities together to work on their goals. And so does that help answer that question at all?
I think it just shows the complexity of the issue. And I understand the rural deal. We discovered that with the K-12 mental health pilot program in the small towns. It really helped for parents to be able to come to the school building to receive services because nobody knew why they were showing up at the school building. So I understand that. But I think it's a little more complex than just, well, we want to make them comfortable here, we want to make them comfortable there. And I think there's going to be a lot of questions. I just want you guys to all understand that there's complexity and rate parity.
Yeah, okay.
So, okay. Questions, comments further? All right, thank you very much, Kathy. Appreciate you being here today. Last but not least, we have Walt Hill, Executive Director of High Plains Mental Health Center. Welcome to committee, Walt.
Madam Chair, thank you very much. Appreciate the time to visit members of the committee. My name is Walt Hill. I'm the Director at High Plains Mental Health Center. We provide services to 20 counties in Northwest Kansas. We've been in existence since 1964. We have a staff of about 150. We treat 6,000 plus patients each year. 8% of our funding comes from counties, about 25% from mental health reform. Vast majority of our funding comes from fees. We operate about a $10 million business operation as a nonprofit. I think the issue that's before us is one where, I think it was a Chinese term, that crisis is both threat and opportunity. And what we're trying to do is make an opportunity out of the threat of the COVID crisis. And I think we're doing that. And I think around telehealth particularly, we can learn a great deal, both in clinical delivery and in how we operate the larger system, the business side of operations. We started telehealth in 1997. Kyle asked me to research what the model was in this picture. I told him it was a 1952 make of a 1978 therapist. I think he meant the computer, which was a Pentium 1 with Windows 90 something And if we were lucky, it hooked up to a dot matrix printer. We started this through something called the Telepsychiatry Network of Kansas with quite a few of the mental health centers. We interconnected all of our offices across Northwest Kansas, which would allow patients to not have to, say, drive from Goodland to Hayes to see a psychiatrist, or vice versa, which increased the time and the cost to deliver that. You know, in 1997, we were primarily concerned about Y2K that was coming at the year 2000. I think we should have been worried more about 2020. I think it's more of a threat now. You know, there are always issues before us that we are dealing with and that we make it through our creativity and ingenuity. And so I appreciate your committee looking at, you know, the future, not and helping us not get stuck in the current struggles and crisis. Next slide, please. So since 1977, we connected all of our branch offices, which is 5 offices at our main offices, to primarily deliver psychiatry services out to folks that live in our predominantly frontier areas of our catchment area. Our next step was then to connect almost all of the jails and hospital emergency departments with telemedicine equipment so that we could see patients in an emergency in the middle of the night. We could see prisoners at jail who were having a mental health crisis and do screens for state hospitals, determine if someone needed to come to a psychiatric hospital, give advice to a local emergency department on how to manage the patient that was before them, and reduce significantly the amount of travel. Before we implemented this, we often had a therapist on the road for 3 hours in the middle of the night, driving from, say, Osborne to Norton, or from Colby to Goodland to see someone in the hospital or jail, and had huge delays for law enforcement in hospitals. So that was the second step of our evolution with using telepsychiatry. As you've heard today, there are major challenges with workforce in psychiatry. In fact, last week, our medical director, psychiatrist of 25 years retired, which brought home the comments today about the maturing of the psychiatry resource in our country, and the changes that brings. Psychiatry has become a much more lucrative, competitive specialty in medicine. It used to be one of the lowest paid specialties. Now it's the 3rd highest demand specialty. And we have trouble recruiting in Kansas and nationwide, but particularly in our rural and frontier areas. Psychiatrists generally are folks who want to live in more metropolitan area. They would rather go to the opera than hunt pheasants in Graham County. And that's just the nature of most folks in psychiatry. So we developed a relationship with John at Innovatel. He and I belonged to several national organizations. We sat on a forum that Patrick Kennedy held on telemedicine, and we developed a relationship and began building the use of telepsychiatry outside of our walls so that we could maintain our capacity of psychiatry to take care of about 3,000 patients a year that need psychiatric medication services. And that has evolved till a point now. We have 2 psychiatrists and 3 psychiatric nurse practitioners with Innovatel who see patients both at our offices and in patient homes. As we've talked about, Kathy talked about, John has talked about, that newest development which our patients have very much appreciated. As I listen to national experts talk about the evolution of healthcare, healthcare is much more going to be an on-demand expectation of consumers, be that if I have a sore throat, I may want to be able to call or get my primary care doc on Zoom. And if I'm traveling, the expectation is that access is changing. John talked about same-day access. Telepsychiatry and other sorts of virtual care, and I want to make sure to emphasize that there is virtual care that's well beyond telepsychiatry. It involves apps, it involves what's called asynchronous services, text messaging. It involves, in some cases, I think a little bit of this is happening in parts of Kansas, where we have patients who have high degree of disability having home monitoring to make sure they're safe and can readily access help so that they can live on their own through whether it be physical or behavioral interventions, measuring if someone leaves their stove on, for example. The centralized hub will know that that's happening. The fourth evolution, which I think has really pushed us ahead, is our response to COVID. I want to emphasize, I've been thinking a lot about this, that therapy is one thing, and providing Zoom-based therapy is part of what we do. But as a $10 million business, I also have to make sure John at Novotel gets paid every week or every 2 weeks. I'm not going to have a psychiatrist for my patient. I have to make sure my staff get paid, that I have to pay my bills, that I have to put the check from KDADs that I get every quarter into the bank to pay those bills. So virtual service delivery is broader than telemedicine. It involves electronic health records, as Kyle's talked about. We are on the precipice through Spark funding of developing a system where if our staff all had to be at home for a year, could not come into the office because of quarantine, we could run our entire operation with people at home. Our business operations, and we believe that that is a posture to set. We hope we don't have to use that, but we are needed to move from the era of paper purchase orders and invoices into a whole new era using technology. Could you switch the slide, please? So barriers in parts of our area, our broadband capacity depends on various areas. Now, Representative Smith was talking this morning. Wallace County, for example, we do have a televideo outreach office in Sharon Springs. The cost of broadband continues to come down. I think will, though, level out, and the broad applicability of broadband so that we can connect with a farmer in his tractor and deliver a telemedicine service while he's out in Wallace County is going to be important. So wireless broadband 5G is going to happen. Right now, we still are challenged with having sufficient bandwidth for what is a really fast growing demand. The payer restrictions that you heard about earlier are a concern, be it in Medicaid, in commercial insurance. We are still challenged with some of the issues of with various payers with credentialing of our staff to get them on board, be that right now trying to get a psychiatrist licensed in Kansas and authorized by the managed care companies or through KDHE. The opportunities, though, I think far outweigh the barriers. We'll figure out the barriers together. but delivering home-based services for us, reaching into the agriculture community, which is a major initiative that we have, is a great opportunity. Over the years, putting televideo in jails has been a wonderful way of partnering with local law enforcement and local hospitals. I must say that the telephone-based services have been very well received and appreciated by our patients, some of whom do not have broadband, who can't afford a smartphone or an iPad. I would just mention that issue about what service is appropriate for telephone versus televideo versus face-to-face. I think is, as you said, Madam Chair, a very complex issue, including not necessarily age, but the complexity of the type of problem that a child or an adult comes to us with. And I think there are some national guidelines to help us with determining that. None of us want to misuse the technology and miss the needs of patients, but it is something I think we do need ongoing conversation about, but that providers can do a pretty good job in determining that without strict external rules. As I mentioned, patient monitoring, I think, may be a real opportunity in the future of the internet connected pillboxes to make sure our patients are taking meds. Monitoring their blood glucose at home, because some of our medicines create elevated glucose in some of our patients. And again, the ability to move all of our operations, be it clinical and business, into this current era of really the ability to multiply our effort through electronic communications, be it clinically or in keeping the business open. Next slide. So I'm going to, this is some data I put in the slide deck for you that shows what we did during COVID. It compares face-to-face versus virtual services. These are patient encounters. If you go to the next slide, it compares patient hours. You see in a couple of months, our patient hours in April and May really dipped. We made a decision. We didn't care if we got paid for services. We sent all of our staff home with iPads, and it took a while to gear up, getting all of that in place, our patients understanding that they could still be served. And I do have another slide I'm going to show at the end that's not in the slide deck that shows a very interesting story about what we were able to do in continuing to reach out to our patient population. But yeah, we decided it didn't matter if we were going to get paid or not. We were just going to take care of our patients. That showed up in our bottom line after the first 6 months of the year. We're about $500,000 in the red, but we're going to, work our way out. There are other funds that have come to bear, payroll protection, Spark, the local COVID money. But we focused on taking care of our staff, making sure they were safe, and taking care of patients. Something, if you switch to the next slide. Something we did while we had those staff at home working for us, still getting paid, we asked those that weren't directly seeing patients, call the patients who are getting telemedicine service and ask them how it's going. We want to know, is this satisfying their needs? And this is the data we had from 745 patients. We made 2,600 phone calls, talked to 745 patients, talked to them, interviewed them. And what we found is many of the patients got their services by telephone, some by televideo. They felt they could communicate with their provider, that 93% felt they could clearly communicate using virtual services. We asked overall satisfaction. 87% said that they agreed. They were satisfied with telehealth and found it helpful. And looking to the future, we said, how do you feel about using virtual services going forward? And it was a pretty even third split. About a third of patients said either way is fine, virtually or face-to-face. A third said we'd rather come into the office. And a third said we would rather get our services through virtual service delivery. I have, and I couldn't share all of this, but I have about 550 comments from patients, their narrative report about their response to of having services delivered in this way. Some didn't find it great, but many said it was a great experience. Some were just happy that they could keep getting their medications refilled or talk with their therapist through this difficult time. And that was really the predominant. One says here, it makes it easier for me when I'm busy. I'm still able to get the help I need. Some said, I feel much better, more comfortable getting therapy at home. So we have done some real in-depth looking at this, not just saying, well, this is all we can do. We ask, is it good enough? Is it good? Because we wanted to know, is it something that we could continue to do, which we have. So if we could switch out of the slide deck, if it's possible, and unshare the screen. I have what turned out, I couldn't get this done before the deadline to turn in the slide deck. This is month by month the number of patients we served back to October of last year. We generally saw around 1,900 to 2,000 patients every month throughout that whole period. So the first message was your community mental health system in this state continued to take care of Kansas citizens. Even though the COVID hit in this period, we still had nearly as many patients coming into High Plains. And I know from talking with my colleagues at other mental health centers, that was a very similar experience. We made it happen so that people did not fall through the cracks during this very difficult time. What did happen is the black line, we were providing about 500 patients with virtual services every month out of about 2,000. That went up to almost 96% of patients in April were taken care of with virtual service delivery. And it resulted in our continuing to be able to serve all of the patients who needed to be served. Now we're beginning to see the virtual service percentage drop down. However, it's almost at twice the level that it was before a lot of the restrictions were here. And we closed our offices. Our offices are open now, though we are still challenged because we have a variety of staff who are sent home for isolation, quarantine. They see their patients by iPads at home. We bought over about 120 iPads that we've deployed. We have mobile electronic medical records so that staff can see their patient from their home at the patient's home. And it has been a very quick ramp up. But I think it speaks to the resiliency of the mental health system in Kansas, that we tend to have a bit of a frontier mentality, that we're going to take on challenges, meet them where they're at, come up with creative ideas. And I think there's some things within this response to COVID, both clinically, business operations, even financially, that will perhaps serve us well in some areas as we meet the ongoing challenges of modernizing our mental health system in the state. They aren't the complete lessons about this, but I think the thing that served us very well is we decided we were going to take care of whoever needed the service. We would worry about figuring out how to get it paid for later. And I think as we move in the future, there are technology opportunities that help some with workforce. I am concerned about workforce because we have fairly low compensation levels for our staff. I had a case manager today tell me that she could go work at McDonald's and make as much, and that's the case. Our funding subsidy for the uninsured has not really risen since mental health reform back when we worked on that in the late 80s. We appreciate the legislature having restored and the governor's office restoring those funds, but we are still well behind the maintenance of effort in keeping up with the huge demand of, I believe, 120,000 or so Kansas citizens each year that are served, many that don't have insurance. And our counties are unable to participate anymore financially. They're struggling. So the challenge is how to have adequate compensation for staff and staff who want to live in rural Kansas, because we still need boots on the ground staff to work with people face to face. And we have to make it attractive enough. Some of the things you were talking about earlier, I think could be very helpful with incentives, with education, getting people into the workforce, streamlining the processes through BSRB, but ultimately being competitive with salaries with the states around us, in my estimation, would be is the number one challenge. I recruited for a psychiatrist for 6 months and was unable to find a psychiatrist to move to Hayes. So I've switched to the virtual services. It may be that that is all that we will have as virtual services. I hope that that does not happen. But we are having people my age, who are going to be leaving the field. We have psychiatrists, psychologists, mental health folks who are going to be aging out, and we are not refilling those spots in the workforce at the same rate. I'll stop at that point. Would be glad to stand for questions that you might have, and appreciate the chance to tell our story and offer what we've learned through responding to COVID through telemedicine, maybe having some lessons that are helpful for the future of our system.
Thank you all. Questions? Anyone on Zoom with questions? Well, I do appreciate the graphs that you gave us. You know, it gives us a good visual picture, and you know, perhaps the one that you weren't able to get in earlier that you showed us on screen, I think it would be good for us to have that in our files and
yes,
given out to our others. So if you'll get that sent to David, then
yes, I'll send it to David as soon as before the end of the day today.
well, it doesn't have to be by the end of the day, but
Oh, get her done.
All right, well, thank you very much. We don't have any questions for you today. I'm sure we will in the future, though. So appreciate you being with us today.
Thank you.
All right, committee, that concludes the agenda that we had before us. Our next meeting is October 30th at 9 o'clock, I believe is what we've got set. So I know you're all excited about that.
I get to dress up.
Senator McGinn, question?
So how many more do we have after that? And did you get another one? Or I was just reading some of the extensions.
We got two left. So we have a total of 6 days. And this will make us that will have us using, we've used 4 of them.
On the 30th, we'll have, we'll have 2 after that. Okay, all right, thank you.
We're hoping not to have to extend that. It just depends on what it's going to take for us to pull together our report and what we can prepare for potential legislation. So everyone needs to be thinking kind of along those lines on where we might want to head with some of these things. So we know that, we may not be able to get the complete 10-year plan, but we think we can get at least something out there that moves us forward and then continue working during the legislative session. So we're adjourned until 10:30. October 30th.
That's nice.